any further delays, we can start. Welcome on behalf of the parent Indian Society of Electrocardiology body and the organizing committee of the midterm ISECON 2023 at Solapur. I think this is a very unique initiative by Dr. Parale to engage the postgraduates in internal medicine and cardiology, and I think it will go a long way in engaging the postgraduates in our education programs through the year also. Uh, it's always nice to be competitive, and your generation is already used to the competitive spirit since your undergraduate days. So we'll employ the same rules here, what you have been used to. With the time constraints, I have planned to do 12 questions. I'll read out the question because sometimes there are short forms, so that you are not confused regarding that. Then I will ask somebody to start the timer. In 30 seconds, the timer can go off, and then we can move to the next question. So there are 4 options, A, B, C, D. You mark, there's only one correct answer, so you mark that. If you mark correctly, you get 4 marks. If you don't choose to mark, you get 0, and if you answer wrongly, you are -5. So think about your answer. It's a joint answer between 2 of you, so don't mark 2 answers. So once we finish the 12 questions, I'll request them to take your answer sheets and score them. And in the meanwhile, we'll go through the answers and we'll explanations, and we'll also engage the audience to give some answers. I think time is the biggest constraint. So without any further, are the set of rules clear to you? It's quite simple. So once I read, I'll ask the timer to start. You can give 30 seconds. While I read also, you're already thinking. So I think you'll totally get about 45 seconds or so. Should be enough. Or how much you want to give? 1 minute? 30 seconds. 30 seconds enough? Okay, 30 seconds. Yeah. So you guys are ready? No questions? If 1 minute, they'll tabar right. We'll give 1 minute so that you can. We'll give 1 minute so that you can put your best foot forward. 4 marks for correct answer, 0 if you don't answer, and 5 if you give a wrong answer, 5 minus. So 1 extra minus. Yeah? I do not know what was the level of the preliminary. You know what level I did for the online quiz. I don't know if the preliminary was tougher because Dr. Parale is a taskmaster, so maybe it was tougher and the final round might be easy. So cool off and let's start. Okay? So all of you concentrate. Question 1, look at the ECG carefully. A permanent pacemaker is not mandatory in a patient with this office ECG if, and then you can read the options, choose the correct statement. So look at the ECG carefully. Permanent pacemaker would not be required if it is a asymptomatic patient. Patient has recent pre-syncopal symptoms. You put him on a stress test and you show that he goes to a higher grade of AV block. And somebody thinks that the symptoms are suspicious, does a EP study, and the HV interval, which is for the distal conduction problem, is 80 milliseconds. Only one of this statement is correct. The time starts now. Give them a minute. Look at the ECG carefully. Why am I thinking about a pacemaker? 1 minute is over?
No, start.
Start, okay. Right. So I'll say time starts now, then you can think of start your minute from that time onwards. And you press when the time ends after a minute, so that we can move to the next question.
Yes.
Look carefully at the ECG. Why do I want to consider the need of a pacemaker, a permanent pacemaker? And when is it not mandatory? So at least 3 of the options will say that it is proper, it is indicated to give a pacemaker or implant a pacemaker. One option suggests that you don't need to do a pacemaker.
Time, sir.
Okay. We move to the next question. All these questions are meant to understand your ability to understand the cardiac activation and things like that. So they are not really too hi-fi. Sustained monomorphic VT is a scar VT. You must have heard that many times yesterday. What is the underlying cause of this VT? So it is not only important to diagnose a VT, but try and find out if there's a, you can say what is the cause of the VT. Remote inferior wall MI, remote anterior wall MI, arrhythmogenic right ventricular cardiomyopathy, or I just cannot determine, it's too wavy here. So ECG must tell you about the, you should be able to say something about where this VT is coming from, where is the scar, what could be the cause of this, and I think some of these things you have heard yesterday. Your time starts now. So your time is starting. It's purely ECG reading. At the end of it, while we explain, I'll ask you to discuss one after another. Just now you can silently mark. Have a good discussion amongst each other. There should be a reason why you make that answer. If you have a right reason, you will be right. As always, two answers are close, the other two can be discarded easily. You have done your needs 100. You know how it goes. Okay, your time stops. We'll go to the next question. This patient has hypertrophic cardiomyopathy. You know one of the most common features of that is asymmetrical septal hypertrophy. Which ECG finding suggests the presence of a septal hypertrophy? Tall R in V4, V6, deep Q in 1, V5, V6, no inverted T waves. This patient does not have a septal hypertrophy. Your time starts now. You must understand the cardiac activation and what makes, which part of the QRS is related to the septal activation. That's the hint I'm dropping. It's hardly pushing you in time. If you give a thought, it is a question of 5 seconds. Just a matter of applying a little mind. Okay, we move on to the next question. This is a 35-year-old man under evaluation for palpitations and remote syncope. Which echocardiographic finding is likely based on this ECG? He is likely to have had an inferior wall, regional wall motion abnormalities. Are you likely to see RV dilatation with severe PH? Are you likely to see RV dilatation with normotensive TR? Or is it compatible with a dilated LV cardiomyopathy? Based on the ECG, you should be able to suspect what the echocardiography is likely to reveal. You can challenge an amateur echocardiographer if he reports something funny. My ECG does not correlate with your echo findings. So that is the position of the internist. Whatever you are good at, you should be able to push your diagnosis. Your time starts now. Sorry. Internist is a much better reader of the ECG. If the echo tells you something funny, you should ask the echocardiographer to review his findings. Although echo is far more sensitive way of diagnosis, particularly when it comes to left ventricular hypertrophy, but sometimes a first year resident in cardiology may not be better than you as an internist. So look at the ECG carefully. What is the abnormality? It's a very classical ECG of a particular abnormality. That's the hint. It's a very classical ECG. You know, these exam findings and publications bring out all classical things, whereas in clinic you always have vague things to deal with. Okay, next slide. Change gears. Guess the site of origin of this atrial tachycardia. So I am not asking you to diagnose atrial tachycardia. If you look at V1, you can really clearly see there is a atrial tachycardia going on. What is the site of origin of this atrial tachycardia? I do not want to make electrophysiologists out of you, but just that if you understand the orientation of the atria and the position of the leads, you have to make choice between only two. Left atrium is the origin, right atrium low in the crista, multifocal, so different morphologies, or right atrium high crista. Crista is a terminalis structure on the anterior RA. Your time starts now. We might discuss why we try to localize the atrial tachycardia on the ECG. As a physician, using medicines may not be directly relevant, but for ablation it is relevant to know. Yeah, fifth. What is the origin of this atrial tachycardia? Okay, we move to the next question. This patient was brought to the casualty with 2 syncopal episodes at home, brought or rushed. What is the emergency management? This ECG shows is compatible with vasovagal syncope, do nothing, wait for him to wake up. Deliver a shock and start IV amiodarone. Deliver a shock and insert temporary pacing wire. Deliver a shock and start IV lignocaine. Your time starts now. Look carefully at the ECG. I mean, that's why you are here. Okay. Shall we move on to the next one? This is a ECG from a 8-year-old child. The tachycardia that you see here, narrow QRS, regular tachycardia, terminated with IV adenosine. What is the diagnosis? Are you going to look at the ECG or the adenosine? That is the tip here. Is it atrial tachycardia, orthodromic AVRT, AV reentrant tachycardia, antidromic AV reentrant tachycardia, or AV nodal reentrant tachycardia? Your time starts now. I hope the ECG is big and clear to you. So you must have heard yesterday something about long RP, short RP. Narrow QRS regular tachycardias look for the P wave. It's all about ECG reading, understanding the difference between how the T wave looks and how the P wave looks. Okay, we go ahead. This patient came to the emergency medical services at 2 o'clock in the night. I'm not telling you the presentation, but what is the best management plan when you have this ECG on hand? You would put a temporary pacemaker now and advise the relatives that you're going to put a permanent pacemaker tomorrow. You would put a temporary pacemaker now and shift the patient to the cath lab to do primary angioplasty, where you will intervene in the right coronary artery immediately. Or you would put a temporary pacemaker now and shift him to the cath lab, and you probably will have to open the circumflex artery. Or you will put a temporary pacemaker now, stabilize the patient, and before discharge you would give a dual chamber ICD. So again, your time starts now. Look at the ECG. How many findings are there?
Dr. Madhikar.
Answer करतो सांग ना. There are two options there. One is emergency and one is a planned option in the therapeutics. So obviously there must be two diagnoses there. Another hint is there are always two answers which are close to each other, and that's testing your skills of ECG reading. Okay, we move to the next. I hope the speed matches with your ability to think. I'm not pressing you too much. Okay, again, if you understand the cardiac activation, this patient has arrhythmogenic right ventricular cardiomyopathy. What is the site of VT origin? Right ventricular outflow under the pulmonary valve, right ventricular inflow near the tricuspid valve, right ventricular apex, everybody understands that, or left ventricular origin, left ventricular free wall. Now this is not about having read about ARVC, this is about understanding the cardiac activation, and when it happens, when the VT originates from a particular site, how would the 12 lead ECG look? So this is not about having knowledge about ARVC, forget that. Look carefully at the polarities of the 12 leads. Yeah, I think your time has already started. Sorry. We are through 75% of this skill testing. How many prizes are we giving? How many winners would be there? Two or two? So you have a good chance. Okay. We move ahead to the 10th question. Again, nothing of this is about how much you have read, it is only about how good you understand the ECG. Recognize this atrial tachyarrhythmia correctly. Is it atrial fibrillation? Is it atrial flutter? Is it atrial tachycardia? Or I am at sea, it is too many waves there. So you have to just understand your definitions of how different atrial arrhythmias are defined. Your time has started. Probably one of the easiest questions of this series. You cannot have negative marks on this. Two more questions to go. It makes a difference which of these it is for ablation, for prescribing anticoagulation, for prescribing the right rhythm control drugs, whether to choose rate control, rhythm control. It matters if you can recognize this correctly. We can discuss that later. Now, something about pacemaker ECGs. I have a talk later in the day, but how many cardiac sites are paced? Only one. Right atrium, that's where you put your atrial lead. Two sides at least, right atrium and right ventricle. Three sides, right atrium, right ventricle, left ventricle, or four sides, both the atrium and both the ventricles. So look at the pacing spike and what follows it, and why we are calling there could be three or four sides also. Your time has already started. Sorry. I hope we require a tiebreaker after the 12th question. That would say that you are fiercely competitive, or my questions are simple for your standard. The ECG machines nowadays filter the pacing spikes so much that you have to little bit strain your eyes to sometimes even say what is being paced, but probably not in this ECG. Okay, we go to the last question. At least you must not gather negative marks, but at the same time you must get at least 4 marks. This is a narrow QRS regular tachycardia. What is the appropriate diagnosis? It matters a hell what diagnosis you make, what treatment you choose, what can be curative, what can be the best way to go ahead. Is it a fascicular VT? Is it VT after a remote anteroseptal MI? Is it orthodromic AV reentrant tachycardia? Is it idiopathic outflow tract ventricular tachycardia? Your time starts now. Last question. At least one of these you can eliminate easily, but the rest three will require some good ECG reading. So after this, करतो ते मागे जाऊन. For the other postgraduates in the hall, I hope you are also in your mind trying to answer. And if you volunteer answer when we discuss, it's equally welcome. Last 10 seconds or something? Okay. So thanks everybody for coming all the way, participating. You have to be thankful to Dr. Parle for this initiative. You can hand over your OMR sheets while we discuss quickly as to
Take some time because we have to calculate the result. If
how
there is a
I
tie,
will
if
question.
there is a tie,
Then
we have
the
to-
3 questions आहेत. हां एकच मिनटं हे देतो. करेक्टला 4 नाही दिला आन्सर तर 0 रॉंग दिला तर 5 मायनस करायचे म्हणजे 1 मायनस म्हणजे 5 जातील असं नीट आहे. हो -1 बरोबर -1 म्हणजे 0 4 गेलेच ना 0 4 नाही मिळालेला अजून म्हणून 1 मायनस. येस 1 मायनस. हां सांगितलं का तू नंतर करतो ना. ओके. So I think we can discuss a bit if your answer sheets are handed over. We'll start from this side and you can get up and volunteer. It's no name and shame. It is just that all of us want to learn and probably the others in the hall will learn from your thought process. So
Excuse me, sir. Just 1 minute. I would like to invite the chairpersons for the session, Dr. Panchanan Sahu, sir, Dr. Satish Pawar, sir, and Dr. Chandrakant Patil, sir. Sirs, please join the stage.
Sure.
As well as Dr. Sunil Karande, sir.
Okay.
Dr. Dilip Apte, sir. Sir, you are requested to join the dais.
So your checking is over. So the first question here was, permanent pacemaker implantation is not mandatory if you find this office ECG in a patient that you are seeing. Choose the correct statement. Can the first pair, one of you can get up and just give them a mic, na? Yeah. Just pass on kara after each question, next person. Yeah. So try to answer and then we will discuss it out. Just that we want to move fast so that we are over in good time. Yeah. Say, you can go and speak in the mic. No issues, whether you are right or wrong, it's more for discussion now. You're right bundle branch block, you agree about it? Yeah, and the right bundle branch block, so you see RSR dash in V1, so it's a right bundle branch block, complete right bundle branch block at that if you like, and the axis is leftwards, right? So if you have a right bundle branch block, usually it goes with a normal or a slightly rightward axis. If you have a discordant axis, that means you are having additionally a left anterofascicular block. And the PR may be slightly full or 240 milliseconds. So if you have a bifascicular block, and sometimes people say if PR is long, a trifascicular block, it's a misnomer, but you have a bifascicular block. Now, if this patient has a history of giddiness, syncope, anything of that sort, symptom is suggestive of bradycardia, he may be landing up in paroxysmal AV block intermittently. If he has any of the symptoms which are convincing, then you can think that that is happening, that is worsening to a paroxysmal AV block intermittently. If he has symptoms which are dubious when you take the history, you might have to investigate further. Many a times the non-invasive test that you do is a stress test. In a stress test, a distal AV block, if it is there, it worsens. So right bundle branch left axis would go to a higher grade of AV block, and your answer is made that it requires a pacemaker. Sometimes even that is not clear, and you do a EP study, and in one of my yesterday's talks I said that if during a EP study you measure the HV interval, that is a reflection of the intra or infra his delay or block. If you have AH and no V, means it is a distal block below the bundle of his. Then again it is a clear indication for a pacemaker. So all B, C and D patients would require a pacemaker in all likelihood. Only a asymptomatic patient who completely denies symptoms, and maybe that ECG is done for some LIC purposes or some pre-job checkups. It's only in that situation that you may not want to investigate this patient further, and there is no reason for you to suspect that he has intermittent worse bradycardia than what you see on the ECG, and only in that scenario is the pacemaker completely not an indication. Yeah, any question? Okay, seems to have been a tough question. Okay, what is sustained monomorphic VT is a scar VT. What is the underlying cause of the VT? The next pair can answer. You can identify your name for the... So this is a VT. I have already told you that broad QRS tachycardia, right bundle branch block, right axis, right bundle branch block kind of a VT originates from the LV. So you can concentrate on the LV pathology, right? So you can rule out an ARVC, which is a right ventricular cardiomyopathy. So C you can rule out. D is something that you should try to avoid at 0 mark, cannot determine. There must be a way to find out what the etiology is, where the scar is. Yeah, you want to answer?
So we are not sure about it.
You're not sure? Sure, okay. So basically, you agree that it's a VT. The most important reason is monophasic R in V1, deep Q in V5, V6, or a negative complex in V6, and a axis that is, well, not the axis, a concordant axis doesn't help. Right bundle branch block, right axis doesn't necessarily help to say it's a VT. A discordant axis helps. But anyway, monophasic R, deep Q in V5, V6, it's a VT. Now what helps you to decide the etiology is the QR pattern. I did not say QS pattern. If you see a QR pattern in any of the leads when there is a VT, it helps you to say where the scar is. Can you say which leads have the QR pattern?
Sir, anterior leads V4.
Very good. Yeah, so V1 you can be a little strain your eyes and say there is a small q to start. In V2 you see there is a q but probably ends with a small r. From V3, V4, V5 you can be relatively sure that there is a QR pattern. So a QR pattern tells you where the scar is, not the QS pattern. Yeah, remember this, otherwise every QS pattern you would think there is a scar there. A QR pattern tells you where the scar is. So the scar is in the anterior wall, so the correct answer would obviously be B. Okay, to the next pair. This patient has hypertrophic cardiomyopathy. Which ECG finding confirms that there is a asymmetric septal hypertrophy?
Sir, dagger like Q waves are seen in V5, V6 and 1 and AVL. So that points towards HCM because in septal activates from left to right. So in lateral leads we can see Q waves.
Excellent. I had no bias to give an easy question to them, but it happens by chance. So the septal activation, as rightly said, is from the left to right. And if there is a septal hypertrophy, that part of the QRS would be more amplified. Just like in left ventricular hypertrophy, you get V5, V6 or 1 AVL becoming taller because there is more mass to be activated. Similarly, same logic here. More septal mass activation is from left to right. That is reflected by the Qs in 1 AVL, Qs in 1 V5, V6, which you can see are extra deep here. And that indicates a septal hypertrophy. To the next pair now. This 35-year-old man has palpitations and syncope episode or a history of syncope, which echocardiographic finding is likely? So what does the ECG show, and then we can easily guess.
So in ECG, there is a strain in the RV. Like V1, V2, V3, there is a T wave, DP wave inversion. So it indicates the RV strain pattern more likely. So it could be the RV dilatation with severe pH.
Half of it is right. This pattern is typically, you have a terminal R wave in V2, V1, and probably some prolongation of the QRS in V3, V4. And if you understand the ventricular activation, the right ventricular outflow is the last part of the biventricular activation. Any delay in activation or any slowness is activation is by that prolongation of the QRS, that part of the QRS. So here the last part of the QRS is delayed or prolonged or slurred or whatever. So the slowness of conduction is in the last part of the QRS, which is an equivalent of RV activation. So this pattern is typically called as epsilon wave, and the negative T waves are a reflection of the depolarization abnormality. So you have a repolarization abnormality also. This is typically suggestive of RV pathology. So you have to choose between B and C, right? Now with severe pH, you have a very tall R in V1, V2. If you have seen the ECG of mitral stenosis or primary pulmonary hypertension, you have a tall R in V1, V2, not a broad like this. So this ECG is very typical of an epsilon wave in arrhythmogenic right ventricular cardiomyopathy, which obviously does not have to do with severe pH. Sometimes there is a biventricular cardiomyopathy when you can get, but for discussion's sake, let's see, it is an isolated ARVC, and with RV dilatation you can have some TR, which is a normotensive TR. So therefore the correct answer would be C. I can sense that the questions were a little tough. I am curious to know the marks. I think the fifth pair is more intelligent. Let's see. Guess the site of origin of the atrial tachycardia. So again, it is no electrophysiology here. The left atrium is a structure. See, the heart is not oriented in a sagittal plane like this, right? It is like this. So the left atrium is to the left and posterior. The right atrium is to the right and anterior. And that would reflect on your precordial leads that way. So something that originates in the left atrium is activating the two atrium from posterior to anterior. Something that originates in the right atrium is activating the two atria from anterior to posterior. So what was the correct answer? What was your answer?
So we didn't mark this question.
You marked?
We didn't mark this question.
You didn't mark this question. So here you can see V1 is positive, right? If in an atrial tachycardia, V1 is positive, the origin is from the, after my explanation, can you?
Left atrium.
Yes. So it is distinctly left atrium is because it is positive in V1. Most commonly in hypertension, where the left atrium is affected, in mitral stenosis or mitral regurg, where the left atrium is dilated, the atrial arrhythmias would originate from the left atrium. When do you get multifocal atrial tachycardias? If you have heard yesterday?
COPD.
Yes. Yeah. The last pair, this patient was brought to the casualty with 2 syncopal episodes. What was the way you managed this patient? Which college are you from?
So GMC Kolhapur.
Solapur?
Yes, sir.
Wow. Tell me. What are your findings on this ECG?
So patient, before the syncope, he has a complete heart block.
Excellent.
And then the rhythm is a torsades.
Excellent.
So we'll first give a shock, and after that we'll go for pacing.
Excellent. Very good. So if you have been careful to look at the first part of the ECG, you see there is a complete heart block. You can see 3 P waves at least which don't conduct, right? One on the top of the T wave, and then the 2 are very apparent. And then there is one following the QRS, right? So this one is not conducted, this one is not conducted, this one is not conducted, this is following the QRS. So there is a complete heart block. Patients with complete heart block have a bradycardia, As a part of bradycardia, they tend to have a QT prolongation, and when they have a QT prolongation, they are prone to torsades, and that's what is seen in the ECG thereafter. So people with complete heart block can have syncope because of two reasons. One is bradycardia, and the second is a torsade like this, and torsade becomes much more emergent, that you shock him, put a temporary pacing wire, and plan for a pacemaker, permanent pacemaker, as soon as you can. Again, coming to the first pair, this ECG is definitely a narrow QRS regular tachycardia, which terminated with adenosine. So you bet on which option? Antidromic tachycardia is out, right? Antidromic tachycardia is a broad QRS tachycardia, it's out. The rest three is the struggle. It terminates with adenosine, so gives you an impression that the AV node is a part of the circuit. You block the AV node and you, but again, that is also something that I am trying to mislead you by saying adenosine helped. Many of the atrial tachycardias are sensitive to adenosine and they terminate. I say this is atrial tachycardia. Do you agree with my answer? That's where I gave you the hint that the P waves are rounded and not broad-based like the T waves. So if you look carefully at some of the T waves, you have to see this is a P wave, not a part of the T wave. This is another in V2, if you see, this is a P wave, not a part of the T wave. It's rounded, no? Like a P wave, not like a T wave. And you have a long RP tachycardia. A long RP tachycardia cannot be a AVNRT or orthodromic AVRT. It is an atrial tachycardia. Yeah. We will have a tiebreaker. It's a low scoring match, is it? India West Indies World Cup of 83, low scoring. We'll know the answers. Okay. Best management plan for this patient. Next pair. Temporary pacemaker now is a common answer there, so no marks for that. You can easily see complete heart blocks, no marks for that. Question is, what is following the temporary pacing? Is it angioplasty or is it pacemaker? Is it some electrical device? Yeah. Do you see ST elevations?
Yes, sir.
Excellent. Did you see that, guys? There is an inferior wall MI. So, how do you localize the culprit vessel in the inferior wall MI? Yeah. Lead 3 more than lead 2 means occlusion of the RCA. So, your correct answer would be B. PAMI is primary angioplasty. I guess all of you are now equally familiar like us. Okay, next pair. This patient has arrhythmogenic right ventricular cardiomyopathy. They get VTs from the right ventricle. So they have those VTs have a left bundle branch block pattern. Now look at the limb leads to tell me where is this VT originating from.
Sir, V1 is negative, so it is right ventricular.
Yes.
And 1 and AVF show left plexus deviation, so it is right ventricular apex.
Right ventricular? Apex. Excellent. Now, there are more things to argue for that. It is a negative concordant, almost a negative concordant pattern in precordial leads that can happen when something originates at the apex. Plus the axis is northwest, so they two match up. Anything from apical origin, always a ventricular tachycardia. Negative concordant pattern V1 to V6 and a northwest axis. So you cannot be talking of outflow because then 2-3 AVF is positive. That's easily ruled out. Left ventricle is easily ruled out because it's a left bundle branch block morphology kind of a VT. The toss was between inflow and apex. We said why it can be apex. Next pair. Again simple. Recognize this atrial tachyarrhythmia correctly. Many of us have a habit of calling fibrillation flutter, flitter, whatnot. Yesterday only we said that you have to be discreet in the diagnosis because atrial tachycardia does not have the same prescription for oral anticoagulation as AF and atrial flutter. Ablating atrial tachycardia and flutter is much more less cumbersome than ablating fibrillation. Rate control is easy with fibrillation, rhythm control is easy with flutter. So there are n number of reasons why you must make the difference. It is not only academic exercise, but definitely important for the management plan. Your answer was?
Atrial flutter.
Excellent. So atrial flutter is at a faster rate than tachycardia, does not have an isoelectric line between them, and the morphology of the P waves remains same from beat to beat. So that distinguishes it from a tachycardia or a fibrillation. Next pair, how many cardiac sites are activated? So you have to count the number of spikes that you see. How many spikes do you see?
Sir, we have not marked this question.
One you can see, or two, or three, or four? Yeah, so if you see three, I am impressed. So there is one before the atrium, so that paces the atrium, makes a P wave. The second paces the ventricle, but if you really look carefully in some of the leads, you will see that there is one big spike and probably another spike once the QRS starts getting activated, yeah? So there are indeed three spikes, but if you didn't see the third spike, you can easily understand that usually the ventricular lead is put in the RV, and if you pace the RV, you will get a left bundle branch block pattern. In this case, you have a right bundle branch block pattern, so there must be something else happening. When you pace the RV, you can get a northwest axis, but you don't get a right bundle branch block pattern like this. And therefore, when you see a right bundle branch block type of a paced QRS, you should suspect that the LV is also being paced. And this is done through a CRT pacemaker or a biventricular pacemaker. So you have to see if there is a third spike, or you have to guess on the basis of the right bundle branch block pattern. Yeah. So there is nothing like pacing the four chambers yet, but okay. Last one, last pair. Narrow QRS regular tachycardia. Would you like to jump on orthodromic AVRT, or would you think amongst the other three options?
Orthodromic AVRT.
Well, that's obviously the wrong answer since we are sitting in the quiz. Narrow QRS regular tachycardia, it's a right bundle branch block pattern, right, in V1. And what is the axis?
Left axis deviation.
Very good. So right bundle branch block, left axis. So the axis is discordant to the bundle branch block pattern. So therefore, whenever that happens, you can be rest assured most of the times that it's a VT. Yeah. So when you see any tachycardia, bundle branch axis discordant to the bundle branch block pattern, think of a VT. What confuses you is that it's a narrow QRS, and you are right that 85-90% of time a broad QRS tachycardia would be there when you see a VT. So, but what helps you is the discordance in the axis with the bundle branch block. So right bundle branch block left axis goes with a fascicular VT or a VT originating from the left posterior fascicle. But that's not the answer, because you see a QR pattern in V1 to V3, and whenever there is a QR pattern, there is a scar. Where is the scar?
Anterior
In the anterior wall, correct. So therefore the answer is VT with remote anteroseptal MI. Low scoring match? So you are tied up at low scores or high scores? Let's hear from the organizers. Yes, any tachycardia can have electrical alternance. It doesn't necessarily give the diagnosis, but yes, that's a good thing to recognize. Yes, so why this is narrow is something that I forgot to explain. Is if you have a VT originating from the septum, if the VT originates from the free left ventricular wall or right ventricular wall, the two ventricles are activated sequentially, one after another. Whereas if the VT originates from the septum, the two ventricles are activated near simultaneously from the VT focus. Therefore, the biventricular activation time is less and the QRS is narrow. Some of these answers you answered very well in the online quiz, I think. Were you a little tensed up in the offline? Okay, we'll have the scores from the organizers, but unless we require a tie, we have a tie, we should be good. Tie nahi hai. Okay, so by the time we get the answers, we'll just for the sake of revision, for the sake of interest, do this. Okay, okay. So I think Raja is ready, or? Yeah, he's ready. So I'll stop here, and I think thanks everybody for joining. and let the best pair become the winner. We'll know later. Okay. Thanks.
Cardiology students for the quiz. Yeah, please occupy the front chairs.
Please have a seat. DM students for quiz.
Baba, Baba. Leave the corner chairs out. Sit in the center. Five. Okay. Like leave the corner chair.
हेलो 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 3 है हेलो चेक चेक हेलो हेलो हेलो
Hello.
Yeah, I think while we are setting up to start, all of you can just briefly introduce yourself, your names and which institute you're from. So we'll be counting the teams from here. So this will be team 1, 2, 3, 4, 5.
हेलो
I'm Dr. Pooja Prasad.
I'm Dr. Sudipta Mandal from Sri Chitra Tirunelveli Institute for Medical Science.
Sorry, from where?
Sudipta Mandal from Sri Chitra.
From Sri Chitra. Both of you are from Sri Chitra? Okay.
Hello, I'm Dr. Karan Kalani.
I am Nikhil Singhania. We are from Jipmer, Pondicherry.
I'm Chinmay Parade.
Ramanathan from Jipmar, Pondicherry.
Gunjan Shah from UN Mehta, Ahmedabad.
Dr. Shubham Sharma from UN Mehta.
Okay.
Kunal Marathe from Jayadeva, Bangalore.
Saurabh Limay, Sion Hospital, Mumbai.
All right. So, we can put up the first slide. So the way we're going to do this is, we have 4 rounds. I've set up for 4 rounds. And the first 2 rounds, the first round is going to be not ECGs, just something related to, so don't move now. So these are just going to be some basic questions, and these are going to be in a multiple choice format. And so there'll be no passing. So you'll have 5 questions, and I'll go from team 1 to 5 onwards. And if you choose the correct answer, you get 5 points, and otherwise you get no points. So you can always make a guess. The second will go from team 5 to 1, so we'll come in the reverse order. And these will be ECGs, and again multiple choice. So the multiple choice should not take too much time. So these will be 2 rounds. After that, we have a third, where there'll be no choices. So it'll be ECG and open-ended questions. So there it will become more important to give a complete diagnosis or be able to understand an answer correctly. So because there's a little bit more understanding involved there, you will have some variable scores. Like if you give the complete answer, I'll give you 10 points. And if I think your answer is not complete but still correct, I'll give you 5 points. And you'll get 0 if you're not able to answer. And here there will be, the question will pass. So if either you pass the question or you make a wrong answer, it will go to the next team. But the next team, if they give a complete answer, they'll get 5 points in passing. Okay, so all these. And then after that, after that we'll have a buzzer rounds where it will become, all the questions will be open to all the teams. So I'll just put up each question. And at any point, even before I read the question fully, any of you can choose to be the first to answer that question. So you press the buzzer. Once you've pressed the buzzer, you're committed. So if you make a wrong answer, you'll get -5. So you'll get negative points here. And again, you'll have 10 or 5 points depending on how complete your answer is. Okay? So we're all set up now. And so Pramod, you're keeping scores, right? So, okay. So the first round, we'll go from team 1 to 5 onwards. Okay? So we'll put up the first question. I'll do it, yeah. So round 1. Okay, so these are fairly basics in ECG. Some of this has been covered in the talks yesterday. So the question is, you can read the question. I mean, basically, positive deflection is recorded in the ECG when wavefront moves towards the positive electrode, wavefront moves towards the negative electrode, wavefront is parallel to the recording lead, or wavefront is perpendicular. So pick the answer which is the most correct.
When wavefront moves towards positive electrode.
Towards the?
Positive electrode.
Correct answer. So you'll get 5 points. Okay, so we'll move to team 2. So Eindhoven, as you know, like it's called the father of electrocardiography, was recording the first ECGs. The question is, when Eindhoven was recording the ECGs, how many leads did he record? Was it 1 lead ECGs, 3 leads, 6 leads, 12 leads? So you'll have 30 seconds to pick an answer. 6 leads. Okay, so that's the wrong answer. You give 0 points to team 2. Yeah, I mean, there's no marks. You want to answer, you can answer. 3? 3 leads, good. Because, like, you know, lead 1, 2, 3 are the bipolar limb leads. And the augmented leads came later, right? Goldberger later got the augmented leads, so they were added on later. So Eindhoven only had the 3 leads, and you have the Eindhoven's law and all that, right? Okay. So we'll move to the third question for team 3. Notch filter in an ECG is used to remove notches due to movement artifact, to remove AC noise, remove myopotential noise, or to remove baseline wander.
It is for removing AC noise.
Removing AC noise is the correct answer, so we'll give 5 points to team 3. Okay, so again, just to cover the basics, like removing notches, of course, notch filter doesn't come from the term of removing notches. Notch filter is basically a filter which removes a notch of frequencies, which means frequencies around a certain particular basic frequency. And they are there to remove AC noise, which comes at a particular fixed frequency, 50 hertz for us. And myopotential noise is typically a high frequency noise, so it has to be removed with a low pass filter, and baseline wander is a low frequency noise, is typically removed with a high pass filter. So team 4, your question now. You can, when you place electrodes beyond a certain distance from the heart, they are considered equidistant. What is this critical distance? Is it 10 centimeters, 15 centimeters, 20 centimeters, or 30 centimeters?
15 centimeters.
Very good, 15 centimeters. So that's 5 marks. So again, as you know, like the recording electrode, the amplitude of the signal, everything depends on the proximity to the heart, right? But it falls off very fast as you move away from the heart. It falls as a square of the distance. So once you go beyond 15 centimeters, so if you have a lead at 16 centimeters or 25 centimeters, it's equivalent. Which is why if there's an amputation, it doesn't matter that you put your electrode on the ankle, you can put it on the knee or put it on the hip. It is going to record the same ECG. 15 centimeters is the correct answer. Okay, question 5. The PR interval on the ECG, what does it represent? AV nodal conduction time, AV node and his Purkinje conduction time, interatrial AV nodal and his Purkinje conduction time, or sinoatrial, interatrial AV nodal and his Purkinje conduction time. So what are all the components? So you have 30 seconds, you can think and answer.
Option C, intraatrial, AV nodal and his Purkinje conduction.
Very good. So why is it not the fourth one?
If P wave
Sinoatrial time is not something that you can see on the ECG, and whereas all the other three contribute to the PR interval. So very good. So I think the first round, except one team, all the others got the answers correct. So the second round, like I told you, would now be again multiple choice, but you'll have ECGs, and we'll go in the reverse order. So we'll be starting with team 5. So I'll skip 6 question here. So we'll go to the second round. Okay, so I'll give you a little time to see the question, so don't start the time now. So you can see the choices in this. So patient has a pacemaker. Look at the 4 choices, and we'll start the time now.
Option C.
Option C. Okay, so that is the correct answer. So you can give 5 points to team 5. Good. So what is, can you just, do you want to quickly explain what you saw on?
Actually, there is one sinus beat coming where there is no AV block. So AV block is out of the question. Now it is about sinus node dysfunction. There is the pacing is good. After that one, sinus beat is coming. So the option B is also ruled out. So between C and D with less time, we didn't analyze further.
So but you picked option C, right? So why did you pick dual AV nodal?
For atrial bigeminy, I couldn't.
Excluding other things.
Because I couldn't see 2 P waves anywhere.
Okay, fine. I mean, you didn't really fully understand the mechanisms, but anyway, the answer is correct. But what we are saying here is, one is it's not AV block. Like you said, you can see AV conduction is fairly normal. So this is sinus bradycardia. It is VVI pacing. But following every pacing spike, you see a P wave and a QRS and a narrow QRS. Now the P wave is inverted in the inferior leads. So this is not a sinus P wave. This is, and this is not atrial bigeminy. It's not coupled to the thing. So most likely what is happening is there's a long VA interval because the VA conduction is going through a slow pathway and it comes back antegrade through a fast pathway. So this is echo from the VA conduction. This is because the patient has a dual AV nodal physio. But anyway, you get 5 points. It's good. So next to team 4. Patient with syncope, what is the diagnosis? So you can start the time. So you have 30 seconds to pick your answer.
Sir, it is a atrioventricular block.
So you're picking answer B, right? Choice B. Right, 5 points to team 4. So that's the correct answer. Can you just explain?
Sir, actually there are two P waves. It is a 2:1 AV block. If we look at the right side of the lead second,
Very
the
good.
rhythm strip, there a P wave is visible which is merged with the T wave and a narrow QRS, so probably it is a supraesian type of twist.
Right. So this can easily be misdiagnosed as sinus bradycardia because it looks like a one-to-one conduction with sinus rates being a little slow. But 2:1 AV block is something you should always remember can easily be missed because the second P wave is a little bit hidden. Especially the PP intervals around the QRS are shorter because of the ventriculophasic arrhythmia and they can be short. Here, like you said, the clue is that if you see the T waves, you can see towards the end slightly this separates out a bit. So that gives you the clue that there's actually a P wave there. So the correct answer is that this is actually AV block. So now we'll come to team 3. So again, you see a little irregularity in the RR intervals. The question is, what is the correct diagnosis here? Is this first degree SA block, second degree type 1 SA block, second degree type 2 SA block, or second degree type 1 AV block? So your time starts now.
It's a second degree type 1 SA block.
Correct answer. So 5 points to team 3. So again, Ramanathan, you want to quickly explain?
On grossly seeing, there is a group beating that we can see.
You can see group beating.
And the PP interval progressively shortens before one P is being dropped.
One?
PP interval progressively shortens before a P wave is being dropped.
Where is the drop P wave? If you have a P wave dropped, what would be the level of block? It will be beyond the P wave. It will be in the AV node. But this is not AV block, right?
It's not AV block.
You were saying SA block.
SA block.
So you won't have a P wave which is dropped. You'll have an S which is dropped, which is a sinus deeper, which you'll not see on the ECG.
It is not seen here.
Right? So what you said is correct. You have progressively shortening PP intervals before a pause that is less than twice the shortest, and then again starts with a long PP interval. Actually, what is happening is there is progressive prolongation of the SA interval. And then there is one beat of SA block. But the SA interval, like we discussed already, is not something you see on the ECG. Right? So this is second degree type 1 SA block. Okay, so team 2, your question now. What is the most likely diagnosis? So you have the age of the patient and you have the ECG. What is the most likely diagnosis? I mean, it's obvious that all can be possible, but generally, like, what is it most likely to be?
Sir, it's atrial tachy. So there's a long RP interval,
so
and
you picked atrial tachycardia, so that'll be the wrong answer. So you'll give 0 points. So you want to say? Yeah. You said AV and RT? Okay. So now the thing is, one is, it's a regular narrow QRS tachycardia. The P waves, I know, are sometimes difficult to see, but actually P waves are somewhere here. It's a short RP tachycardia. It's inverted P waves in the inferior leads. But like Dr. Asirvadan was showing yesterday, this is a thing where it's not very short. It's a little longer than very short. And also you see QRS alternance, right? You can see in some of the precordial leads very clear-cut QRS alternance. So putting all these together, a fairly fast rate, 200 or above, with short RP but shorter than the typical AV and RT, and QRS alternance makes a diagnosis of ORT the most likely diagnosis in this case. So question to team 1. What is the mechanism of this tachycardia? So I'll give you 5 seconds to look at it before starting the time. So this is ECG record in the ECG lab. So it's all 12 leads are displayed in this. We'll start the time now.
Right-sided pathway with orthodromic reentrant tachycardia.
Right-sided pathway to orthodromic. So that will be the wrong answer. So, yeah. I mean, I think you would have broadly got the, understood the principle that you have transient bundle branch block during a narrow QRS tachycardia. And during the bundle branch block, you can fairly easily see visually that it is slower, right? The intervals between the QRS complexes are longer. Now, when a tachycardia slows down during bundle branch block, it indicates ORT using a pathway on the same side as the bundle branch block. That's where you made the mistake, right? It's a left bundle branch block. So this is a pathway on the left side. That would have been the correct answer. So we finished 2 rounds. Can we just have the scores?
Team 1 5 marks, Team 2 0 marks, Team 3 10 marks, Team 4 10 marks, and Team 5 10 marks.
Right. So teams 3, 4, and 5 are tied at 10, and then you have 5, and you're yet to open the account, right? So fine. No issues. We still have rounds which are higher scores. So we'll move to the 3rd round, where, like I said, I mean, you have a chance of scoring more, because if you give a complete answer, you can get 10 points. And so we'll switch back again. We'll be starting from team 1. I'll also give you more time to answer this, because here you'll need to give a complete diagnosis. So self-explanatory, pacemaker clinic patient coming here. You see something. The part that we see here is also zoomed out there. So have a look, take some time, and then give me a complete diagnosis. Okay, so we'll start the time now. You have 1 minute to think.
There is a dual chamber pacemaker with initial bits showing A paste, first bit showing A paste, V paste.
Right.
Then followed by one atrial paste bit is shown. Followed by there is no pacing spike, ventricular pacing spike. So there is a loss of pacing output there after the A paste bit. And
so what do you think is the primary abnormality?
Ventricular oversensing.
Oversensing of?
Ventricular lead.
You're saying oversensing in the ventricular lead?
Ventricular oversensing. It is sensing the atrial pacing spike.
What is that called?
So far field oversensing.
Okay, so where do you see that?
Crosstalk between.
Crosstalk. And where do you see that? Here, you're saying this point.
Yes, yes, sir.
Do you see it anywhere else also? I mean, is it only in this beat, or in any of the other beats also do you see evidence of crosstalk? Okay, so I'll give you 5 marks, okay? So you won't get the full 10, you'll get 5 marks, because you are moving in the direction of the right answer, but you had to be led a bit. So you're right. Whenever you see that pacing doesn't happen where it should be happening, you think of oversensing, right? So, okay, somebody else wants to answer? Yeah, Chinmay, you want to just...
So this second bit in lead 2 has a very short AV delay.
Yeah.
And after that it is waiting for one P wave which is not conducting. Then it is pacing at a fixed AV delay for some time, which is getting prolonged again.
Right.
So probably this is managed ventricular pacing.
No, this is not, no, the answer is correct, crosstalk. But so that's why we've given them marks. But what crosstalk has done here, so you see the sensed AV delay here. Compared to that, this is shorter, right? So normally a paced AV delay would be longer. So this is shorter. So this is because, and if you see here, this is not 80 milliseconds of managed ventricular pacing. This is actually 110 milliseconds. Okay? So this is ventricular safety pacing. So the ventricle is sensing the atrial pacing spikes. That is what is called crosstalk. When this sensing happens within the ventricular safety pacing window, it will produce ventricular safety pacing, which is pacing at 110 milliseconds after the P wave. When it happens outside the pacing window, sometimes the trailing edge goes outside and just falls outside the pacing window, it actually results in crosstalk and inhibition of ventricular pacing, which is the dangerous thing that we're trying to avoid. So you see both those manifestations here, but the primary diagnosis is crosstalk, and you see it both in the form of VSP and inappropriate loss of V pacing. So now question to team 2. Again, you can take some time. So a small child who's had cardiac surgery, and they've called because child is intermittently having bradycardia, which you can see on the strip here. So this is a single strip, and full 60 seconds is shown, 30 seconds here and another 30 seconds here. Okay. So take your time. We'll start the time now. So you have a full minute. Think about it and answer.
Hello. This is an irregular narrow complex tachycardia, but we can see clear P waves. At some points, we can also see a functional AV block because the P wave is falling within the T wave of the previous beat. But the PR interval is normal. It's about 120 milliseconds in the conducted beats. So most likely the AV conduction here by itself is normal. There's no organic AV conduction disease. But because of the increased supraventricular rate, that is atrial tachycardia, whether this atrial tachycardia, it's now positive in lead 2, so it could be sinus, but it could also be a focal atrial tachy coming from a near sinus origin.
So what is your diagnosis? If I'm asking you to tell you the diagnosis in one phrase, so what is your diagnosis?
Atrial tachycardia with variable conduction.
Atrial tachycardia with?
With variable conduction.
Variable conduction. Okay. I think we'll pass the question.
QRS
so
morphology.
team 3.
So post cardiac surgery, so can be junctional ectopic tachycardia, which is blocking in the V and conducting in the A.
Okay.
So some
pass to team 4.
Probably after the fourth QRS, there is one more P
No,
wave.
so you can just tell the diagnosis. What are the diagnoses?
Sir, there is 2:1 AV block intermittent Venkeback.
2:1 AV block.
Intermittent.
Okay. Team 5? No, you don't want to take it? Yeah, okay, fine. So, sorry, team 1. Okay, so no team gets any marks for this question. The answer I wanted you to give is atrial bigeminy. Okay, so it's atrial bigeminy. You can clearly see sinus beats. So there's no ongoing tachycardia. Okay, you see sinus beats and you see P waves here. And when the bigeminal PAC blocks, it doesn't conduct, it produces finally sinus bradycardia because of the pauses following this. And sometimes it conducts and you can see the bigeminal pattern, right? So this is PACs in bigeminy, which are sometimes conducted and sometimes become blocked PACs resulting in bradycardia. Right? Okay. So question for team 3. Middle-aged male with an irregular pulse. Again, just have a look and you should give a complete diagnosis. So we'll start the time now. Yeah. So at the end of your time, you'll have to give your answer. Yeah, so you have to give your answer now.
It's a sinus rhythm, and between we have ectopics, probably ventricular ectopics with retrograde conducting, which are also conducting to the atrium. P waves are also seen after the premature complexes. And then that is causing resetting of the sinus node, and then the cycle is continuing.
Okay, so I'll pass to team 4. Team 4, you want to make it right?
Sir, it is sick sinus syndrome with intermittent infraesian escape, ventricular, wide QRS escape.
Team 5.
Rhythm with intermittent VPCs, and beat number 5 is also a junctional beat with retrograde conduction.
Team 1. Team 2, yeah.
Sinus rhythm, the origin most likely from RV and RV outflow.
Okay. See, just making the diagnosis of PVC is fairly straightforward. That's why I didn't want to give points to anyone. Anybody in the audience wants to tell what is unusual about this? I mean, we all agree there is sinus rhythm and there are PVCs from the RV inflow. Not really. I think they're all, this is parasystolic. So that is the thing here. So whenever you see PVC, look at the coupling interval, right? So you can see the coupling interval here, 480, coupling interval here, 400, coupling interval here, 640. You see here itself, very clearly it's not coupled to the basic sinus rhythm. And then, I mean, it's of course difficult here for you to visually look at the interectopic intervals, but you can roughly see that also. Once you get this clue that it's not in a fixed coupling interval, then you can start looking at this also. See this, it's actually, this is a basic interectopic interval, this is twice that, this is also twice that. This is parasystole. So, should identify this lack of coupling to sinus beats. Okay? So, we finished, that was team 3's question, right? Okay, so team 4. Persistent palpitations, young female. What is the likely diagnosis? We'll start the time now. So you should tell what are the most likely diagnosis and why you're making that diagnosis.
Can we answer?
Yeah.
So there is AV dissociation. So there is a VT going on. RVB morphology with left axis deviation, possibly a fascicular VT.
Okay, yeah. So once you know the
Posterior fascicle, left
okay.
posterior.
Yeah, fine. So that is a complete diagnosis. We'll give you 10 points to team 4. So like you said, this is a young patient and has a wide QRS tachycardia which is not very wide. Right bundle branch block morphology, has a left axis, and you can see V's more than A because you can see like a sinus beat here, you can see a P wave here, you see a P wave here, you see a P wave here. So V more than A. So therefore this VT. And with this relatively thin right bundle, it's idiopathic VT from the left ventricle, and with the left axis, it is coming from the left posterior fascicle. So this is idiopathic left posterior fascicular VT. So question to team 5. So I'm not giving you any clinical details. This is the ECG recorded. What would be a diagnosis? Okay, we'll start time now.
So we can see ventricular pacing, but there is no preceding A wave. So, and V1 shows right bundle branch morphology, sir. So we are seeing a left ventricular biventricular pacing likely, sir.
So what is your complete diagnosis? Rhythm? You said no P wave. So why there's no P wave?
Sinus node dysfunction, sir.
So you're saying the sinus node dysfunction with biventricular pacing. Okay, so we'll decide later about giving you partial marks. I'll see whether team 1 wants to answer.
This is AF with CHB for which and probably LV dysfunction. That's why biventricular pacing was done. So AF, probably AV nodal ablation might have been done with biventricular pacing, CRT.
Right.
Basic diagnosis AF with CHB.
Okay.
So LV dysfunction.
Team 2, do you want to, if you have any different answer from what has already been said? Team 3?
Sir, AF with AV junctional ablation and biventricular pacing with probable pacing from the biventricular pacing and probably from the left bundle also.
Right. Okay. Fine. I think we'll give 5 marks to team 1 because I think they came closest to the thing. I mean, you're right that it's left bundle pacing, but I think they sort of came closer to the thing. So good that you identified the no P waves. That is something important to see, that there are no P waves seen. But whenever there are no P waves, think either it's sinus node dysfunction or atrial fibrillation, right? And then you said biventricular pacing. So again, when you see CRT, what is it more likely to be, right? It's rather than sinus node dysfunction, it's likely to be AF. So given the setting and all these things, the diagnosis here that should have been most likely is this is AF with probably LV dysfunction, who has most likely undergone AV nodal ablation or has complete heart block like they said, and has resynchronization therapy. Only thing you said is bi-V, but this is actually a left bundle pacing. But I agree that can be difficult to differentiate. So I think we'll give you 5 marks, okay? So we finished that round and we'll have the scores.
So for this round, team 1 has scored 10 marks.
Can you give the final total scores? Total scores, can you just quickly total them and tell who is leading? So in a way, you're right only that it's biventricular pacing.
Team 1 has 15 marks.
Team 1 is 15.
Team 2 is 0.
Okay.
Team 3 is 10. Team 4 is 20. And Team 5 is 10.
So Team 4 is leading with 20. And Team 1 is second place with 15. Okay, right. So with this, we'll move into the buzzer rounds. So the buzzer rounds give you a chance to, catch up quickly, take some risks if you want. So once I start displaying the questions, as soon as the question is displayed, at any point you can press the buzzer. But like I told you before, we'll have negative points. So if you give us the wrong answer, I'll give you -5. And depending on the completeness of your correct answer, you'll get 5 or 10 points. Okay, and I'll decide if there's not sufficient hints and the question can be passed, then whoever pressed buzzer second can also I might pass it to them.
Sir, one doubt was there. Sir,
Yeah.
here. Sir, what will be if the team who has pressed the buzzer for the first and has answered wrongly? So will it be passed? Will the question be passed?
Yeah, that's what I said. I'll take a call on an individual basis. I'll tell you that if it's ready to be passed. Okay. There's not much hint, and I think the question is still open to be answered. And there's a clear cut. Another team wants to answer. I'll pass it. Okay. So 10, 5 or -5 marks according to what happens here. So first question.
Sir.
Okay, so team 4.
Sir, it's a junctional ectopic tachycardia with P wave marching throughout the QRS. So narrow complex regular tachycardia with P wave marching throughout the.
Okay, so we'll give you 10 points. So because that's a complete answer, like you said, small child post-surgery having a narrow QRS tachycardia with V's more than A. You can see the P waves, dissociated P waves marching through. So the correct answer is it's a junctional ectopic tachycardia. Very good.
So this was team 4, no?
So team 4, 10 points. Okay, so we'll move to the second question. So I think team 4 pressed first. Okay, so team 4 pressed first. Can you, yeah. So you have to answer
Sir,
within 10 seconds.
Yes. 12 lead ECG.
You can just tell the diagnosis.
Mobitz type 1 AV block.
Good. Second degree type 1 AV block. So the only it's a relatively otherwise easy ECG, but the point is that most of that place it's 2:1, where you cannot differentiate, but you have to identify that at one point there are two waves which are conducted consecutively. And when this happens, you can see that there is PR prolongation between the beats, so that it's a second degree type 1. So team 4 gets another 10 points. Okay, so you're ready for question 3? Again, you have to give team 3.
So upon magnet application, the first 3 beats are faster, after that it is slower. So this is TMT threshold margin testing, which is probably seen in Medtronic pacemakers.
So what is the rate here? What is the rate here?
The rate here is 100, sir. 100. After that it is 85.
Okay, and 100, and what happens? I mean, what is threshold?
20% decrement in each pacing in the.
It's only the last beat which is decrement. Fine. So we'll give you 10 points to team 3. So as you said rightly, as soon as, so this is, you can see VVI pacing going on. As soon as magnet is placed, you have 3 cycles at a faster rate of 100. After that, it moves on to a rate of 85, which is the magnet rate. And during these 3 cycles, the last beat is at a lower output. So it gives you an idea whether there is a certain margin for threshold. That is, that even when you come down to 70% output, you're still having capture. So this is threshold margin test. So go to question 4. So who team 2 pressed, right? Yeah, team 2, yeah.
Sinus node dysfunction is the underlying rhythm, and we can see 2 paced ventricular beats in the first 2 this one. So that is most likely a VVI pacemaker with a escape rhythm of with a lower rate rhythm of 60 beats per minute, and hysteresis is also happening since.
Good. So that's important to identify. So I'll give you 10 points to team 2. So like you said, the correct diagnosis is sinus bradycardia, so sinus node dysfunction, single chamber ventricular pacemaker, so it's pacing here. And then once you have cessation of pacing because one sensed beat comes in, you can see there is an escape interval here is longer. Like if you see this automatic interval, you should have expected pacing somewhere here, but it doesn't pace. That tells you that this escape interval is longer than the automatic interval, so therefore there is single chamber hysteresis. Good. All right, question 5. Team 1. Team 1.
Epstein anomaly.
Epstein anomaly is the correct answer. So it's a relatively, I know it's a, once you again see the pattern, the tall P waves, see the splintered QRS, so this is Epstein's anomaly. Okay. So ready for question 6. Okay, team 3.
Pacemaker mediated tachycardia, sir.
Right. Can you tell a more complete diagnosis?
Sir, it is pacing at the upper tracking rate. Upper rate limit is usually kept at 130 beats per minute.
How does it initiate?
It's a premature complex which has happened at the...
Sir, it is initiated with a PAC, sir.
It's a PVC. PVC which is being sensed at the atrial lead, and that continues as the cycle. PVC which is being sensed, which goes retrograde, and it is being sensed.
So I'll give 5 points to team 3. It's not a complete answer. Like you said, it is PMT, but the initiation, you can see a pacing spike here, right? So this is a atrial pacing spike. So there's an atrial pacing spike which doesn't capture the P. Because there is loss of capture, this V is able to come back to the A. And once it comes back to the A, it gets sensed, again produces AV pacing. So the initiating event here is loss of atrial capture. You know, there are a few abnormalities which can initiate PMT because something has to allow the ventricular paced beat to come back to the A. Here it's able to come back because there's loss of atrial capture. So it's not a PVC, but we'll give you 5 points for the correct diagnosis. Question 7. Team 4, yeah.
Sir, there are sinus rhythm with intermittent ventricular bigeminy or when VPC with
What is the site of origin of the PVCs? I mean, if you're telling PVCs, you should tell us.
V1 is positive, so from LV and 2,3 AVF positive, so from superior.
Left superior, and in 1 it is negative, so it should be in the either in the RCC, LCC, near the LCC.
Why PVC? Can this be PACs? Okay, so
not typical bundle branch block morphology.
I'll give 5 points to team 4. It's fine. I don't think we need to pass it. You're right with most of the things. You see sinus rhythm PVCs. One is said bigeminy, but it's actually sometimes it comes as couplets and sometimes as this. And you can see the VA, I mean, the different ways of seeing VA dissociation. But here you can see that this P wave sometimes comes here, sometimes goes inside. So it's a variable relation to the P wave. There's no premature P wave preceding. So these are PVCs. And I think it's broadly fine to say left ventricular outflow tract PVCs. That should have been part of the diagnosis when you told it itself. AVR, AVL negative, tall R waves in the inferior leads, and positive QRS and V1. It's enough to say also left ventricular outflow tract. I think I might have one more question. So, what is the target for the lead here that you're seeing in the center of the screen. Okay, team 1.
Left bundle pacing.
Left bundle pacing. Okay. So, and especially probably the only differential here would have been, you can see a sheath and you can see a fixed helix lead, and differential might have been a his bundle pacing, but I think with the depth of penetration you can see here from the sheath, you can decide that this is actually a left bundle pacing and not a his bundle pacing. Okay, so with that we'll get the final scores. You want to tell?
The last question we have got 10 marks for the first team.
10 marks for the
Team A has 35 points, Team 2 10 points, Team 3 25 points, Team 4 45 points, and Team 5 10 points.
Okay, so team 4, I think you did very well. Most of the answers you gave were very good, very impressive. So they'll be first, and team 1 is second. Again, good show from everyone. All right, thank you.
Thank you, Dr. Rajaselvaraj sir, for the very aggressively conducted quiz, I will say. And thank you all the participants for making this quiz a tougher one. I think everybody from the audience got the level of the quiz. It was very far beyond the expectation. Okay, the prizes for the first and the PG and the DM quiz will be given last at the valedictory function, at which is scheduled at 1 p.m. So, after finishing the quiz rounds, we'll be starting up with the Pacemaker Symposium, which is the first opening symposium for today. So, for the same, may I call upon the stage Dr. Uday Deshpande, Dr. Mukund Zamre sir, Dr. Amit Balirao sir, and Dr. Lakshmikant Kabra sir. I call upon the stage Dr. Anand Malani and Dr. Gurunath Parai sir also. So dignitaries, please occupy the chairs and chair this session. I call upon the stage Dr. Rajaselvaraj sir for his first presentation on conduction system pacing. We know that this is the future of pacing, and Dr. Rajaselvaraj sir has done good work in conduction system pacing, and he is the person for explaining us the merits of conduction system pacing and how it works.
You can have the slides. So anyway, it's a 10-minute talk. I'm just going to give you a broad overview of where conduction system pacing is at today, not showing too many ECGs or going into the technique of the pacing itself. So it has been a long journey. Pacing started as a life-saving therapy for people who are at risk of dying from bradyarrhythmias, and therefore the initial part of pacemaker therapy in history was really only to save lives by somehow improving the rate, and it started with myocardial pacing, which is the easiest to do. With time, we started finding limitations of myocardial pacing, especially in terms of the dysynchrony it produces and the poorer outcomes that is associated with. So because you're pacing some part of the myocardium and myocardium conducts slowly to the rest of the myocardium, We tried to circumvent this by pacing myocardium at multiple sites. So we started having multi-site pacing in terms of like biventricular pacing and then pacing from multiple sites in the left ventricle itself, so that you're pacing at the same time from 3 places or 4 places. But if you think of it, the conduction system pacing conduction system already exists in the heart as a way to rapidly conduct electrical impulses to all parts of the myocardium. So slowly it has dawned on us that we can make use of this native conduction system, and if we are able to capture that with the pacing stimulus, we'll be able to activate all of the myocardium in a more synchronous fashion. So that has sort of been the gradual progression of pacing, and it started with this pivotal paper in 2000. Work had been done on recording His bundle electrograms and also, pacing the His bundle in the EP lab by Dr. Ben Sherlag and others. But even pacing the His bundle in the EP lab, when you do it, you realize how finicky that is. It's difficult to maintain a catheter in position and be able to get capture of the His bundle on a good, consistent basis. And therefore, it's quite extraordinary to think that somebody could consider pacing it permanently. And also extraordinary when you think now that they did this with standard leads without a sheath, so just by shaping stylets and trying to get the lead into the right position. And despite that, they had good results. And this is sort of how it looks when you do this. That PPML is the pacemaker lead, and the other His bundle is a usual quadripolar EP catheter placed there. So you record the His bundle electrogram. Then they maneuver a pacemaker lead to the same position so that you can record a His bundle signal on the pacemaker lead. And then once you start pacing, we can see that we get capture of the His bundle so that you get a QRS after that same HV interval, and the QRS has the same morphology as the conducted beats. So this was the concept of His bundle pacing. But this was cumbersome to do, and so did not really come into clinical practice, and the technique sort of languished for some time, except for some small studies. And really, it became a mainstream technique from the work of the Geisinger group with Dr. Vijayaraman and Ellen Bogan and others, where because they started using the Medtronic 3830 lead, which was a small isodiametric lumenless lead, which was designed for pediatric pacing. So they realized that you could try to use this lead and pace the His bundle, and also using a sheath for this. Once they demonstrated the feasibility of this was a much more easier and reproducible technique to use. And really, it was with this that conduction system pacing entered the mainstream. So these are the hardware that is used. I think the hardware, the Medtronic team told me it's there in the stall, and people who want to go and have a look at the leads or the sheath can do that. The C315 HIS, that's a non-deflectable sheath, which has a 3D curve, has a primary curve for crossing the tricuspid valve, and a secondary curve for taking you towards the septum. And then the lead itself, the 3830, the Select Secure lead. So this is the hardware that we mostly use for these procedures. So the next major advance in this came from Dr. Huang, the thing was that with His bundle pacing, we found that you could recruit the bundle branch even in the case of bundle branch block, because a lot of the left bundle block probably happens within the His bundle itself. But still, sometimes you may not be able to do that when it is a little distal. So the initial idea was that can we try and capture the proximal left bundle? So if you just move a little beyond the His bundle and then penetrate deeper into the septum with the lead, can we capture the proximal left bundle? So that was the strategy with which this left bundle pacing started. But if you see, but capturing the proximal most left bundle is a little bit more difficult. And also because the tricuspid leaflet comes in that place, and you end up plastering the septal tricuspid leaflet to the wall, it can result in TR and difficulties crossing that area. And if you see the excellent pictures from Tavara's first paper on the left bundle and the His-Purkinje system, its left bundle ramifies across most of the LV endocardium. So you can just reach any part of the LV endocardium and you'll capture the left bundle in a way. So we have slowly realized that you don't necessarily need to capture the proximal most trunk of the left bundle. You can capture more distal areas, and once you capture some part of the conduction system, activation would still rapidly engage the rest of the conduction system. So Currently, we have realized that it's fine to capture conduction system at any of the levels. You can do it at the his bundle, proximal or distal. You can do it in the left bundle, again, a left bundle itself, or one of the fascicles of the left bundle. And then sometimes you reach the left ventricular septal region, but don't really capture the bundle. That is called LV septal pacing. All these now come under the umbrella term of conduction system pacing. And because sometimes it is difficult to separate, or that it's not necessary to separate left bundle pacing versus left fascicular pacing, or a non-selective left bundle pacing, or left ventricular septal pacing, all these come under the umbrella term of left bundle branch area pacing now. So, and any of these can again be selective or non-selective depending on whether you have additional myocardial capture. So broadly we can say now, when we say ventricular pacing, we have traditional myocardial pacing, typically in the right ventricle. You have, of course, left ventricular epicardial pacing from the coronary sinus. But for conduction system pacing, we have his bundle pacing, which can be selective or non-selective, and we have left bundle area pacing. The questions that we are dealing with now as we start using these more in the clinical practice, one is, what is the utility of relative advantages, disadvantages of left bundle area pacing versus his bundle pacing? I think in the last 3 to 4 years, the situation is gradually becoming clearer, and his bundle pacing is being used less and less because of various disadvantages, including difficulty in positioning, long-term rise in thresholds, rates of dislodgement, and the much higher thresholds that you generally have, and poorer sensed R waves, etc. Whereas with left bundle pacing, it's easier to do technically, and generally you have much better R waves. We were worried initially about long-term stability, but I think by now we have clearly good data that long-term stability of thresholds and of position is good with left bundle pacing. Another question is about using the fixed helix leads versus the retractable helix leads. The leads with the retractable helix and a lumen for stylet is what we traditionally use for pacing. We have slowly started trying to use these also for conduction system pacing, and we are beginning to understand the relative merits and disadvantages of this versus the lumenless leads. And I think another question is LV selective pacing, non-selective left bundle area pacing, selective left bundle area pacing. How different are these in outcomes? Is it essential to really get selective left bundle capture, etc.? Again, these are all things that we are still exploring. And if you see like a Google Trends, you can see over the last 3 years, people are searching more for left bundle area pacing now and less for his bundle pacing. It really looks like his bundle pacing is on the way out, except for a very few specialized indications. Now, very quickly, I'll cover the areas where we consider conduction system pacing. The most important is for cardiac resynchronization. Other is patients who don't have the classical indications for cardiac resynchronization, don't have already LV dysfunction, require pacing but are at a high risk of pacing-induced cardiomyopathy. And then the indication would be whether it can be used in all patients with bradycardia, even if they do not have a high risk of pacing-induced cardiomyopathy. In terms of CRT as an alternative to the traditionally CRT was only delivered by BiV pacing. Now cardiac resynchronization can be delivered as various things. So conduction system pacing can be used as an alternative to BiV CRT as either his bundle pacing or left bundle pacing. And there is some data, there's not good randomized data, but that if you put together whatever data is there, it suggests it's at least equivalent, probably better, especially in some scenarios. Similarly, now instead of replacing BiV CRT, it can be used as an adjunct to BiV CRT. So you have a CS lead, but instead of placing a simple RV myocardial lead, you can place a his bundle lead, and this is called a hot CRT, or a left bundle lead, and this could be called a lot CRT. And again, there is data suggesting that this could be superior to a BiV CRT or conduction system pacing only in selected situations. In the other, like I said, is patients who are at risk of developing cardiomyopathy. So these are patients who have borderline EFs. When you're pacing them, you would be aware of this kind of situation where patient has an EF of 45%, has heart block. You put an RV apical lead and most of them will come back with pacing-induced cardiomyopathy. Also, patients post-TAVR, patients who have some mild LV dysfunction and are undergoing AV nodal ablation for AF. All these situations, it's better to give them a narrow QRS when you pace them rather than giving a wide QRS. So this is another situation with this. But long-term, would this replace all the other pacing modalities and you would just do conduction system pacing in anybody who requires a ventricular lead? This is something that we still don't know. So I think as we move into the future, we'll understand the advantages of selective versus non-selective, LV septal pacing versus left bundle pacing, and best approach in patients who are traditionally not good responders to CRT like right bundle branch block, And also, we are still looking at long-term outcomes in terms of stability. Especially important is the ability to extract these leads in the long term, because that's an important issue. And with deep septal penetration, we are still concerned about how easy it is going to be to extract these after a few years. We are also looking forward to some improvements in hardware, because if you know, most of this hardware is not dedicated or not specifically created for conduction system pacing. Or even when designed, it was initially designed for his bundle pacing, and some of those you don't need for left bundle pacing. So we're looking at specifically designed leads for this. And also, we want to find ways to combine conduction system pacing with other devices like leadless pacemakers. We're looking forward to a thing where a leadless pacemaker also would be able to capture the conduction system, and similarly also how best to combine this with ICDs. So that is just a quick, broad overview of conduction system pacing as it is. So to summarize, I want to say it's a revolutionary shift in pacing therapy. I think definitely one of the most revolutionary things to happen in pacing in a long time. And it's with the experience we've gained in the last few years, it's very clear that it is going to be an established mode of therapy, and it is going to dominate pacing therapy. In CRT indications, it is clearly non-inferior to BIV CRT, possibly superior. Maybe, and also patients with bradycardia indication who are at risk for developing pacing-induced cardiomyopathy, it might be the preferred mode of pacing. But whether it's going to replace brady pacing for all indications is something that is not very clear at this point. Thank you.
Thank you, Dr. Raja Selvaraj sir, for giving us the glimpse of conduction system pacing. Where does it stand now, and what do we expect in the coming future? So may I call upon the stage our next speaker, Dr. Joy Thomas sir, for his talk on which pacemaker for whom.
Good morning. Thank you very much for this opportunity to talk on which pacemaker for which patient. There are a number of pacemakers available, and having put in a pacemaker, there are a number of modes and parameters which can be adjusted for the patient. But which among this is suitable for your patient is a very crucial thing for the long-term benefit of the patient. Now, what do we achieve when we implant a pacemaker? We have to promote the physiological cardiovascular activity and ensure that there is a satisfactory cardiac output. Cardiac output would mean a product of the stroke velocity, stroke output, and the heart rate, which is decided by the heart rate is decided by the pacemaker what we put in. You have to ensure that it is safe for the patient, and not only that, we have to ensure that your device stays long in the patient. Now, Dr. Raja has already given you an overview about how pacemakers came in, and particularly with conduction system pacing. So right from 1950s it has come, and today we have got complex pacemakers with implantable basic systems which are significantly evolved. And in 2016 we had leadless pacemakers, and the future is going to be batteryless devices which harvest cardiac motion to power pacing circuits. That's what is going to happen in the future. So currently, whatever we have, the objectives would be to preserve AV synchrony when AF is not the predominant rhythm or the rhythm which is chosen for a particular patient, to avoid unnecessary ventricular pacing in the absence of persistent AV block, automatic management of pacing output in the chamber presenting the primary indication for cardiac pacing, and to increase the rate when the patient requires a greater cardiac output, which is during exercise or during other times when his physiological needs increase, and prevention of syncope in the setting of neurally mediated syndromes. Currently, the options which are available are single chamber, which could be atrial or ventricular, dual chamber pacers, fixed rate versus rate adaptive or rate responsive. We have physiological pacing and cardiac resynchronization therapy. And the indications which we all know are sinus node disease, AV conduction block, which could be of persistent or non-persistent type. And you have got other indications like neurocardiogenic syncope, carotid hypersensitivity syndrome, HCM, and AF needing pacing, which is slow ventricular conduction, and intermittent paroxysmal atrioventricular block, and heart failure pacing, and post-interventions, particularly in TAVI and post-surgery for the aortic valve. Now, I'll just give you a few scenarios. Now, this is an ECG of a 58-year-old who was admitted with altered sensorium and azotemia. He's a diabetic marketing executive with episodes of giddiness since a few months. His echo was normal, and neurological assessment was also normal in this patient. Another ECG is a 75-year-old hypertensive with TIA episodes. He was admitted to ICU for a confusional state, and telemetry showing significant pauses. This is taken from the Journal of the University of Florida. And you can see in the telemetry given below, there is a, there is a long pause which indicates might be the reason for the confusional state for this patient. If you look at the echo, you will see that there is a hypertrophy of the ventricle, particularly in the interventricular septum and near the apical area. And the third case, what we have here is a 60-year-old with syncopal episodes, a diabetic post-ACS ASMI, anteroseptal MI, and inferior wall MI. His LV function was, or EF was 42% with mild PH, and the ECG clearly shows complete heart block, and you can see a QRB pattern in V1, and features of anteroseptal MI and inferior wall MI in the inferior leads. The fourth case is a 64-year-old priest with atrial fibrillation and complete heart block and LBB morphology with ventricular complexes. And the echo shows moderately severe LV dysfunction. If you can look carefully at in the echo, you can find that there is a wavy pattern of the ECG clearly indicating the atrial fibrillation. Unfortunately, my computer was corrupted, so I lost the ECG of this patient. But take it from me that this patient had atrial fibrillation, and he had bradycardia as well, despite stopping all the medications which he was taking earlier. And you can clearly see that there is a dysynchrony. If you look at this line here, the interventricular septum and the posterior wall. So he had severe LV dysfunction. So what is the type of pacemaker we give for all these 4 different type of patients? So if you look at this, the workflow chart here, if you have a patient with symptomatic or significant bradycardia, and the next question to ask is, do these people require an AV sequential pacing? If the answer is yes, then you go on to find out whether the patient is able to increase the heart rate on their own. What we mean is whether they are chronotropically competent. If it is so, then you can just provide a DDD and you don't need a rate responsive. On the other hand, if they are not chronotropically competent, and if there is a 1:1 AV conduction, more than 140 beats per minute, like in the case we discussed yesterday, if the patient is able to conduct, then all we need is an atrial pacing. And in this atrial pacing, if they need rate responsiveness, then you can give a rate responsive one. If they don't need it, then you can go for a DDDR pacemaker. On the other hand, if the patient does not need AV sequence, then you can go for a pure ventricular pacing. Now, who are the patients? For example, if you have a young person with a ventricle not showing diastolic dysfunction, and if the patient, as Dr. Raja Selvaraj told, if the pacing needs are very less. For example, the patient is in 6 sinus syndrome, but most of the time, if the heart rate is, let's say, it is required only in 10 to 20% of the time, you can go for a ventricular pacing. Most of the time, in our patients, who pay for the pacemaker, they may not be affordable. So in that case, you can go for a ventricular pacing, provided the need of pacing for this patient is very less, number one. Number two is there is no diastolic dysfunction like left ventricular hypertrophy, like we saw in that other patient taken from the University of Florida case. If there is nothing like that which demands atrioventricular synchrony, then you can go for a ventricular pacing. The need for a rate responsiveness will depend upon whether the patient needs to accelerate the heart rate. So in a patient who is bedridden, let's say an old patient, bedridden, and becomes sick and the sinus becomes sick, shows sinus dysfunction only intermittently and less time of the day, then you can go for a ventricular ordinary VVI pacing. On the other hand, if it is a young patient and his LV function is good, and the need for pacing is less than 20% or so, then you can go for a VVI, rate responsiveness, because this man, when he exercises and he needs a thing, he will need to accelerate the heart rate. So we can carefully choose the programming of the patient. Now, in a young patient who who is just, so let's say 30 years old, and they affordable, but he needs only an atrial pacing. There's no harm in putting a dual chamber pacing, but one can opt for an atrial pacing mode. So you can program it so that in an atrial pacing mode, and later on, if needs to be programmed to a dual chamber, one has the freedom to do it. So the choice of pacemaker, the choice of programming will depend upon the patient, how many years of pacing you're looking at in that particular patient, and of course, the affordability of the patient, whether he is paying it from his own pocket, or whether there is insurance, or whether there is a government agency which is funding the pacemaker insertion. So all of this has to go into the decision of what pacemaker to put in for a particular patient. And of course, what needs to be remembered is that the final thing, the final workflow which is got from a ResearchGate. It shows a sinus node disease. If it is persistent, first find out if it is persistent or intermittent. If the sinus node disease is persistent and chronotropic incompetence is there, then of course you have to go for rate responsive pacemaker. The first choice would be a dual chamber rate responsive with AV management. The second choice would be a atrial pacing with rate responsive. If there is no chronotropic incompetence, then rate responsive is not required, but the same choices. Intermittent sinus node disease will require will be a dual chamber pacemaker with AV management. Second choice will be a rate responsive dual chamber with no AV management, and third choice will be an atrial pacing. On the other hand, if there is AV block and if it is persistent, then and there is sinus node disease, then the choices would be DDR first choice, second choice DDD, third choice VVIR. And if there is no sinus node disease, the first choice will be a DDD pacemaker, the second choice will be a VDD, and the third choice will be a ventricular pacing with rate responsive. If the patient has AF, don't think about dual chamber pacing. Straight away, it is going to be ventricular pacing. If it is an elderly patient who does not require rate responsive, you can just put a VVI. But if the patient needs rate responsiveness, then it should be a VVIR. And if the AV block is intermittent, it could be a dual chamber pacemaker with AV management, and VVI if there is atrial fibrillation. Now, we have heard this talk about the conduction system pacing by Dr. Raja, so I don't want to go much into it, but compared to initially it was his bundle pacing, but the thresholds in his bundle pacing were higher, then they moved to left bundle branch pacing. And does this left bundle branch pacing correct the left bundle branch block pattern? Yes, they do, and that is seen in this particular ECG taken from Huang's. And the left bundle area pacing for cardiac reconnaissance therapy has shown improvement in all the variables like QRS duration, NYHA functional class, left ventricular ejection fraction, and left ventricular end diastolic diameter. And it has also been found to be useful for biventricular pacing, as in this 40 patients with non-ischemic cardiomyopathy with left bundle branch block. You can see here that from the biventricular CRT, 4 patients crossed over to left bundle branch CRT, and it was only 2 patients in the reverse direction. So the treatment effect at 6 months showed a clear improvement with the left bundle branch pacing CRT compared to biventricular pacing CRT. So in a patient who has left ventricular dysfunction and needs a pacemaker, one can consider cardiac resynchronization therapy, which we are all doing for decades. But recently, left bundle branch pacing has come to be an optional one. And left bundle branch pacing for LBB-induced cardiomyopathy, this is an article from Shanmugasundaram Ponnusamy. He is one of the person who has contributed an article in the journal issue of Indian Society of Electrocardiology, which we released yesterday. And you can see in a study of more than 17 patients of LBB-induced cardiomyopathy, the left ventricular EF improved in all the patients. So this is clearly a wonderful strategy for patients with left bundle branch pacing. And this is an algorithm for patients who are undergoing TAVI. If the TAVR candidate has no ECG changes prior to the procedure, no temporary pacing telemetry for 24 hours or at least overnight. But if there are ECG changes and pre-existing RBB, then temporary pacing for 24 hours or at least overnight is required. If these resolve, there is no further evaluation. But if it continues, then they may require a permanent pacemaker later on. Going on to leadless pacemakers, it's been there for quite some time, but what we are going to see now is this is published in New England Journal in February. It shows a dual chamber leadless pacemaker where you have one pacemaker in the atrium and another in a ventricle. So a complete leadless dual chamber pacemaker. So the take home message I would like to say is where AV conduction is robust, atrial pacing provides almost physiological results. Where chronotropic insufficiency exists, rate response function is required. Avoiding unnecessary ventricular pacing is essential in the interest of battery longevity and the prevention of pacemaker syndrome. Where there is LV dysfunction, cardiac resynchronizing therapy or conduction system pacing should be considered, and one should strive for optimum settings and follow up to enrich the patient's life. Thank you for your patient listening.
Just a minute. So I request the chairpersons to felicitate Dr. Joy. I request the chairpersons to be seated. Dr. Joy, sir. So there are a few questions for you.
So two, three basic questions or doubts. If patient is old man, 70 years, 65 years, and his sinus bradycardia rate is 40, most of it is referred for fitness pre-operative. Asymptomatic, rate is 40, 46, sinus bradycardia, not beta blocker, thyroid normal. How to proceed for fitness, or we can give fitness for this patient?
He's an elderly man?
Yes.
Okay, the LV function is normal?
Yes, echo normal, sinus bradycardia 40, 46 rate.
Okay, symptomatic?
No symptoms.
No symptoms at all. Now, if there is no symptoms and if the patient can go for a dual chamber pacer, I'll put a dual chamber pacing and program it to a low rate escape interval so that he can be on his own pacing. And if there is need for pacing, we can have probably a single chamber atrial pacing if his AV conduction is robust.
Patient is asymptomatic, sir. No symptoms. Old man, no symptoms, sinus bradycardia and routine ECG.
Yeah. If there is only sinus bradycardia?
Sinus bradycardia, rate is 40, 46. Old man, no symptoms, we have to give pre-operative fitness.
Well, then why do you want to consider pacemaker?
No. So what we have to proceed? We give fitness directly asymptomatic patient.
If the patient has only sinus bradycardia, there is no need, and is asymptomatic, there is no need for
rate
pacemaker.
46 or below 50, in between 40 to 50 at rest. Heart rate is 40 to 50 in between.
40 to 50. Now, see, one important thing about a patient with a low heart rate and asymptomatic is to consider the physical attributes of this patient. Ask him about his exercise, whether he is doing exercise regularly and all that. Also the fact whether in the past history, whether he has been a sportsman. So there are people who have been excellent sportsmen in their young age and continue to do exercise. And many of these patients will have very low heart rate. And they will be asymptomatic. Now, I know of an 87-year-old man, his name, I don't want to tell his name, who was an athlete in the Integral Coach Factory. This man continues to jog and run today at the age of 87. He takes part in veteran sports. And when he comes to me, follow up, his question was, why is my heart rate is only 45? Yes. Do I require to do any medicine? He's totally not on any medicine.
Okay.
The same thing what you say, but he's 87 years, heart rate of only 47, no symptoms.
But we have to give pre-operative fitness for this patient.
Not necessary.
No.
If he is absolutely asymptomatic, I'm sorry, initially I thought you were talking about symptomatic or LV dysfunction. But if if the echo is normal, he is asymptomatic, I won't do anything. I think this was discussed yesterday's in the ACG session also. Dr. Parale had discussed.
Some people prescribe orquiprenaline to these patients. Orquiprenaline, beta-2 agonist. Some people are prescribing this patient on orquiprenaline, orquibase.
Orsoprenaline.
So
Okay.
whether it is indicated or not indicated?
No. Absolutely not needed. If the patient is comfortable with the heart rate, that's what I said. Go into the history, find out whether this patient, a person who's physically fit and doing a lot of exercise like walking or jogging, his heart rate will be low. It's not to be treated at all. Leave him alone.
Okay, sir. Thank you.
Because once you start antiplatelets, heparin, now pocket formation.
Patient comes to emergency with complete heart block and he has got chest pain. Probably he has occluded the RCA, proximal to the AV nodal branch of the RCA. And the thing to do is he should be taken up for coronary angiogram. If there is a block, it has to be relieved. Many of the patients, I find that after you open up the RCA, patient is on temporary pacing. The very next day, they won't be reading the temporary pacing and they will regain their AV conduction. This is what I have seen in most of the patients. In case they continue to have the AV block even 4 days after the thing while they think, then they require permanent. So you wait up to 4 days and see. If they don't recover AV node conduction after the 4 days after your intervention, then they will require a permanent pacemaker. And in such a case where the patient has had a ischemic event, it is better to go for a dual chamber pacemaker.
Hello, sir. Sir, you said about prior to TAVR, if there is a right bundle branch block, you put in a temporary pacemaker. If it is LBBB, do you have anything?
If it is LBB, most of the times, if the patient's right bundle is quite normal, they usually do not go for any further worsening. But these patients have to be observed in the during the thing because we are putting a temporary pacer, and the temporary pacing has to be there for at least 24 hours. If after 24 hours the conduction pattern of the ECG remains the same post-intervention as in pre, then nothing to be done.
Hello. Sir, one question. Patient is on beta blocker, and he admitted with complete heart block in emergency. He is on beta blocker. Now he admitted with complete heart block. How to proceed?
He was on beta blocker. He has gone for complete.
Now admitted with complete heart block.
Okay, so you put in a temporary pacemaker. Stop the beta blocker, and observe the patient. If the patient's complete heart block recovers, then you just discharge him without beta blockers and any other drug. What was the indication for the beta blocker in the first place? Antihypertensive. Primarily, the first drug of choice for hypertension alone is not a beta blocker. It should be ARB, calcium channel blockers, or diuretics in that order. And the beta blockers come in only when there are comorbidities like ischemia, angina, and all this. So if the patient does not have ischemia, angina, or other things, he does not, or LV dysfunction, they don't require beta blocker. So then you can control the beta thing with the other drugs. Of course, if you are considering ACE inhibitors or ARB, have a look at the renal function also, the urea creatinine and other things.
Again, this sinus, in your slides, like sinus node disease, AV block, sometime all in emergencies now, sinus node disease from surface diseases, like what are at least some names?
Sinus node disease with AV block.
No, sir. Like, that's what. Now we have to analyze whether it is sinus node disease or AV block. So if it is sinus node disease, you are told in the slide persistent or intermittent. So then again, DDAR like that. So now in sinus node disease from surface ECG, how you can tell in emergency conditions?
Okay, so your patient has got both sinus node disease and there is a disease of the AV node also. Am I correct?
AV will understand it very easily.
Okay, LV function is good?
AV function is good.
Okay, if LV function is good and the patient has sinus node and AV node disease, you have to put a dual chamber pacemaker. It's mandatory. You need to pace the ventricle also, and you have to pace from the atrium also. So a dual chamber pacemaker is needed. And if the patient has LV dysfunction also, let's say, then you have to put a CRT, cardiac resynchronization therapy. It will be a tri-chamber pacing.
Okay, sir.
Are there any other questions? So thank you very much. I'd like to thank the organizers for this opportunity.
Thank you so much, Joy sir. Next interesting session would be by Dr. Ashish Nabar sir. The topic being paced rhythm, how to interpret.
Good morning. Great to see you on a Sunday morning, so many of you. I think since morning, those who have attended the quiz saw a lot of ECGs from me and Dr. Raja about pacemaker ECGs. That seems to be the flavor of today morning. I'll start a little bit in a systematic way oriented to physicians' learning. So you see a ECG like this, and can you guess as to what has been the indication for doing the pacemaker? What is the type of the pacemaker? What mode it is set in? What is the polarity? Where are we pacing? These are the number of things that we look up when you see a patient with a pacemaker ECG. Obviously, the indication for pacemaker you have to judge by looking at the P waves, which are at a much frequent interval than the pacing rate. If you see the P waves are at a much frequent interval than the pacing, then the indication for pacemaker probably is a complete heart block. Then you look at what is paced. The ventricle is certainly being paced, and there is no P wave preceding the paced QRS. That means there is no AV synchrony. If there is no AV synchrony, the pacemaker is a single chamber pacemaker. It is pacing in a VVI or VVIR mode. That may not be apparent on the ECG. What is the polarity? If you see the pacing spikes, they are huge. Those huge pacing spikes are these days not seen because we don't use these unipolar pacemakers anymore. Only at the end of battery life, you may see a switch from a bipolar to a unipolar mode, but that is purely an indication of battery nearing its end of life or reaching the ERI. So therefore, this is a single chamber pacemaker implanted for a complete heart block, a old generation of a pacemaker with a unipolar pacing. As compared to that, if you are looking at this ECG, the differences are that yes, the ventricle is paced. Certainly, the pacing spike is small. So it is a bipolar pacing spike. The ventricle is paced. That is very clear. But thankfully, there is a P wave preceding every paced QRS, which means that there is a AV synchrony. AV synchrony is maintained. Atrioventricular synchrony is maintained. If atrioventricular synchrony is maintained, this pacemaker is a dual chamber pacemaker. It is listening to the atrial activity and pacing the ventricle. So it's a dual chamber pacemaker. If atrium is sensed and the ventricle is paced, obviously the indication for doing this pacing must have been a complete heart block. It's not any more difficult to say that. So if you have to complete this diagnosis, it's a pacemaker implanted for complete heart block, a dual chamber pacemaker, which is doing a bipolar pacing of the ventricle. The atrium is sensed, the ventricle is paced, and if you have to hazard a guess of which site in right ventricle it is being paced, obviously the right ventricle is paced because the paced QRS is LBBB type. And if you look carefully at the frontal leads, the paced QRS is negative in 2,3 AVF with the left axis, but more important is to see that the precordial paced QRSs have a negative concordant pattern. So based on these things, you can easily come to the conclusion that this is RV apical pacing, as you can see on the fluoroscopy picture. This was the way we paced for a long time, till maybe about, I think, 15 years ago. Now we don't like to do this because RV apical pacing tends to increase the chance of pacing induced cardiomyopathy. So we started thinking if this pacing in the RV can be done at a different site, or you can reduce the need of ventricular pacing or not pace unnecessarily. Some of these things were alluded to by Dr. Thomas, that if there is already a good AV conduction or a sinus node activity most of the times, except occasionally, then you must make all attempts to reduce what is called as unnecessary ventricular pacing with a view to not getting into a pacing induced cardiomyopathy. Once again, let's come back to ECG reading. If you have to look at this ECG, what you can see is small pacing spikes preceding the P wave. So obviously the atrium is paced. Yeah, these days you have to little bit strain your eyes to see the pacing spikes because the ECG machines filter these pacing spikes significantly. Sometimes you have a great difficulty and you have to look at different leads to see which lead. Thankfully, at least in this ECG, you can see pacing spike in many leads. These are before the P wave. So this is a paced P wave. The PR may be a little longish, but the QRS is intrinsic. That is, the QRS is not resulting from pacing, but it is the patient's own QRS. So this is a atrial paced ventricular sense rhythm. Obviously, this pacemaker must have been put for sinus node dysfunction. Here, I don't think we are trying to guess where it is, where is the pacing happening, where in the atrium. Now the atrial leads are always put in the right atrial appendage, so we never try and find that out, but for the sake of academic exercise, you can see that the P waves are positive in 2,3 AVF, so it's somewhere high in the right atrium, and the polarity is bipolar. So a dual chamber pacemaker can be pacing in an atrial pace V-sense mode when it is put for sinus node dysfunction. It can be pacing in a A-sense V-pace mode when it is put for complete heart block. What sometimes get confusing to physicians is when they see that on the ECG there is A-sense, V-sense, that is intrinsic activity, and they wonder that if this patient has a pacemaker, why is there no pacing spike? This is what I alluded to some time back, that the complete heart block or sinus node dysfunction may be intermittent, paroxysmal. Most of the time the patient may be in good intrinsic rhythm. In that sense, in that scenario, the pacemakers, you use the sensing activity of the pacemaker so that you don't unnecessarily pace either the atrium or ventricle. Each has its own disadvantages. So if you see a A-sense, V-sense, that is a normal intrinsic rhythm, does not mean that the pacemaker is malfunctioning or there is no pacemaker. Obviously, there is a pacemaker which is working correctly. A-pace, V-pace is a rhythm that you see little uncommonly, but I'll give you an example. If somebody received a pacemaker for a complete heart block, he should be having a A-sense V-pace rhythm. But if this patient has a coronary artery disease and or heart failure and is pumped in with a lot of beta blockers, it is possible that his sinus rhythm will slow down and you will have a A-pace, V-pace rhythm. No harm in that because beta blockers are essential in that scenario and they have to be taken to the highest dose. So it doesn't matter if you have a A-pace, V-pace. Thankfully, you implanted a dual chamber pacemaker in this patient and didn't put a VVIR pacemaker for a complete heart block, which sometimes is a practice in our part of the world for the sake of cost reasons. But you see here clearly the advantage of thinking long term for what could be the scenario 10 years later. Now what you see here is there is a A-sense V-pace. Believe me, there is a A-pace V-sense here, and so atrium paced, ventricular intrinsic, and what is happening is there are some PVCs seen. Is the pacemaker falling short? Is the pacemaker not recognizing something? No, actually it's incorrect to draw that conclusion. A-pace, V-sense, good pacemaker function. There is a PVC which comes quite early before the pacemaker needs to act. If the PVC comes early, the pacemaker recognizes that there is something intrinsic happening at a good rate, it stops functioning or it senses correctly, and from that point it again calculates what is called as a lower rate interval, and it will pace only after that lower rate interval expires. So therefore this is normal sensing function. It senses the PVC, nothing bad happening here. Is there any problem here with the dual chamber pacemaker? Well, it doesn't take much understanding to know that there is a dual chamber pacemaker because there are two pacing spikes coming after one another. If you analyze this carefully, for example, in these leads, you can see that the pacing spike is resulting in a P wave, but the next pacing spike, which obviously must be falling in the ventricle, is not resulting in a ventricular capture. So this is capture failure. So if this usually happens when there is a problem with the lead, most of the times the weak link in the pacemakers is the lead. Rarely you get malfunction of the software or the battery so easily. Yeah, you have those reports on and off, but most importantly, you have to understand that the weak link in the pacemakers is the lead. The lead can have a damage in the insulation or in the conductor, and these would usually manifest in either a pacing or sensing malfunction. This ECG clearly shows you there is A pace but no V pace despite the pacing spike. So the battery is not working incorrectly, it is firing a spike, but it doesn't capture because the lead is fractured. So this is A pace, V pace. Now this patient had a dual chamber pacemaker. After 10 years it reached the end of life or ERI indicator, that is elective replacement indicator, and somebody decided to change the pacemaker, do something differently. What is different in these two pacemakers? There is A-sense V-pace here. Obviously it was implanted for a complete heart block. What you see here is A-sense V-pace again, so there is nothing wrong with the pacemaker. Look at this fluoroscopy image carefully, and somebody decided that there was a little LV dysfunction seen, and therefore at the prevalent idea at that time was if you place in the outflow tract, you would probably prevent the worsening of pacing induced cardiomyopathy. How do you know that the pacing lead position has been changed from apex to outflow tract? Is by looking at the limb leads. In the apical pacing, you have negative paced QRS in 2,3 AVF, whereas if you are pacing in the outflow tract, you can understand that the paced QRS becomes positive in 2,3 AVF because you are pacing high in the right ventricle. Come to one more ECG, probably amongst the last few ECGs. Anything more than AV synchronous pacing? Do you sometimes need to do something more than AV synchronous pacing? Yes, that is what I think you heard from Dr. Joy in the previous talk, that we do try and see what is the LV function before we decide what type of pacemaker you want to use. You don't do the same thing like a dual chamber pacing, even if it's a complete heart block, when the echocardiogram shows LV systolic dysfunction or somebody has heart failure with a reduced ejection fraction, because you can bring in more synchrony in the ventricular contractility by doing something more. That something more is either a biventricular pacing where you put a third lead into the left ventricle, or you might have seen from the ECGs of Dr. Selvaraj that you do what is called as a conduction system pacing, where you drive that RV lead into the drill it through the septum to capture the left bundle. That is called as conduction system pacing, which is a relatively new thing. Which amongst the two you should use, I think you can best leave to your attending electrophysiologist. But currently reading ECGs, you can see that this is a pacing where you have the atrium being paced certainly, but also ventricle paced. And what is this ventricular pacing looking like? There is a paced QRS is a RBBB type. So this is obviously not only RV pacing. If that was the case, your paced QRS is LBBB type. So if you see RBBB type, suddenly your antenna should go up that this is not only dual chamber pacemaker. In addition to that, you are seeing that there is a northwest axis. This, yes, you can get this in RV apical pacing, but that then not an RBBB type of a QRS. So the moment you see some kind of a prominent R in lead V1, you know that the LV is also being paced, and therefore this ECG must be coming from a person who has a CRT pacemaker. Now, we can always guess more based on the ECG as to where in the left ventricle you are pacing. And why I say that, because today your LV pacing leads are quadripolar leads. You can pace in any of the two poles. The lead is driven down into the septal, in the coronary sinus tributary, as deep as it can be. So if you're pacing from the terminal poles, you're pacing near the apex, you would get a northwest axis like that. If you're pacing at the base of the left ventricle, you might get a right axis or something like that. So therefore, this is so much of information is what you can derive out of a paced ECG as to where all you are pacing. Basal pacing is, LV pacing is preferred more than apical LV pacing. So you can even hazard a guess whether this patient has a good chance of becoming a responder, that is an improvement in LV function after a CRT pacing. Come to the ECG on right, you can see that there is again a RBBB, the QRS is relatively narrow, better than this ECG, and you have a northwest axis again. So if your biventricular paced ECG results in as narrow QRS as this, I can bet on the table at the end of the procedure that this patient is likely to be a responder, even a super responder if he is a non-ischemic cardiomyopathy. The ischemic cardiomyopathy patients are slightly lesser responders. So I would love to have this ECG on the right at the end of my CRT procedure probably than one on the left. I would even be happy with the left, but the right is more mesmerizing. The QRS is much more narrow. Further, you can see that this paced spike is a little thicker than the atrial spike. So there are probably two spikes falling on each other. So there is a way you can program the LV RV pacing simultaneously versus LV pacing before RV to bring about better hemodynamics, better narrowing of the QRS. This might be extending a bit too far for this audience, but you can even identify LV before RV or LV RV simultaneous pacing. This is probably the last ECG in my presentation, where you just now heard elaborately about conduction system pacing. Now see, conduction system pacing is where you pace the left bundle, or you pace close to the left bundle, or at least you achieve what is called as deep septal pacing. When you activate the ventricles from within the interventricular septum, your biventricular activation time is going to be less, unlike your RV apical outflow, whatever pacing you do. And therefore, the QRS is going to be a narrow. We have traditionally learned that particularly in heart failure patients, the narrower the QRS, the better the improvement in LV function, even lesser the chance of getting into a pacing-induced cardiomyopathy. So nowadays, we tend to love this kind of pacing for almost all patients, although randomized controlled trials are still to come where exactly we should use this. But there is a big enthusiasm to do this conduction system pacing, which results in such a narrow QRS like that. Particularly, you know that you have done a good conduction system pacing if you have a QR pattern like this in the lead V1. So kind of have a photographic memory for this conduction system pacing. This is where we are heading to in the current days. So just a few examples of how the conduction system pacing looks like. So this is the dual chamber pacemaker used in a conduction system pacing, where this lead is clearly driven into the septum. This is another example of conduction system pacing, which is a part of a CRT pacemaker. And this is an example of conduction system pacing where I think the device is an CRT-D pacemaker, where in this case we could not put the CS lead, and therefore we put the LV, what was supposed to be a LV lead is now put in a conduction system pacing manner, and you have the ICD lead. So there are different ways in which you can incorporate conduction system pacing in the current day CIED devices. This is again best left to the electrophysiologist, and even he sometimes has to decide on table as to what would be the most ideal thing to end the procedure with. Let me thank you for your patient listening. Thank you very much.
Thank you, sir. Thank you for a wonderful presentation. Only one question we can take. There are no questions. I request the chairpersons to felicitate Dr. Babar, sir. Okay, sir. Thank you, sir. The next speaker, may I request Dr. Rajesh Dhopekeshwar, sir, for his talk on pacemaker abnormalities.
So, good morning, everybody. Final sessions of this really great meeting that we have had for 2 days. Very happy to be here amongst really big stalwarts of electrophysiology and all of you. I would like to thank Parale sir also. Yesterday also was a good session. So I'm going to quickly finish this talk. Ashish has already clarified a lot of things about pacemaker ECGs. So if you have any questions, we can go ahead with that also. So whenever the pacemaker malfunctions, which is obvious on ECG, many things may be responsible for it. What are the things we would like to list? One is that the pacing is not happening. It could be because the spike itself is not there. So it is output failure from the pacemaker, or if the spike is there but it does not stimulate the myocardium. So there is no P wave or QRS despite a spike. So that is failure to pace. You can say that is the first scenario. Second thing is problem with sensing of the intracardiac signal. So either under sensing or over sensing. So whenever the pacemaker does not sense an intracardiac signal, it would probably give a spike which is not expected, not in an expected situation. That would tell us that the pacemaker is not sensing that intracardiac signal which is seen on the ECG. Or over sensing, when you don't get spikes when you really should get pacing spikes. So 4 different things that could be responsible for pacemaker malfunction, and there is something called pseudo malfunction in which the pacemaker is actually doing its job correctly, but on ECG it appears that the pacemaker is not doing well. Multiple different things that can give rise to that, like crosstalk or pacemaker mediated tachycardias or sensor induced tachycardias, runaway pacemakers. Runaway is not a pseudo malfunction, it's a genuine malfunction, or sleep rates, rate drop response, different pacemaker algorithms, which could make us look on ECG that the pacemaker is not working properly. What helps us tell whether this malfunction and how it is happening is the timing when it is happening. So when you pick up an ECG, just find out when the pacemaker was really implanted. And if it is early after pacemaker implantation, the most easiest thing is that there is a lead dislodgement or the set screw has not been connected properly. Two important things. Second time when you would detect is when somebody comes in with some other acute illness and has had a pacemaker, and there is pacemaker dysfunction which wasn't there earlier. That could be because of multiple metabolic abnormalities or drugs which could potentially affect the threshold of the leads. Third scenario is very late. Patient is already having a pacemaker for a few years and there is a problem or pacemaker malfunction. Then lead problems like subclavian crush or very late battery depletion because of increased consumption or normal consumption of battery. And some abnormalities you just detect them on Holter, which very frequently is just because of the pacemaker algorithms. So anybody who has a pacemaker, you rarely have to do a Holter actually, because pacemaker itself is like a 24-hour Holter, and whatever you want to detect, any arrhythmia, you could get it just by interrogating the pacemaker. And finally, somebody who is in the hospital getting operated and develops pacemaker, despite pacemaker develops bradycardia, it could be just electromagnetic interference. So what is pacemaker failure? You don't get a spike where it is expected. Now here also you are not getting any spikes in a pacemaker ECG. It's just a normal ECG. So you don't expect spikes or pacing when the patient's own rate is normal. So if the patient's own rate is normal or the patient's pacing lower rate is lower than the patient's own rate, then you would just get a normal ECG. Pacemaker is just looking at the patient's rhythm. There are times when you get a rhythm like this in a paced patient, but you don't see any spikes. So I'll just see if I can expand this. So if you look at it really, there will be leads. So this is a VVI pacemaker. There will be leads and you can see very small spikes at the bottom there. So sometimes pacemaker ECG filtering itself makes spikes so small that you have to carefully look at it and not just say that there is no spike. So spikes are there, pacemaker is working well, but it appears as if there is no spikes. So that is not true. The second scenario is when you get spikes, but it is not capturing. And there are many reasons for that. It could be anything from the pacemaker down to the level to the lead or the tissue also, which could be responsible for non-capture. So on the top tracing, there is a dual chamber pacemaker which is correctly sensing, the atrial lead is correctly sensing. The ventricular pacing spike is there, but it is not capturing the ventricular myocardium. In the bottom tracing, you can see a dual chamber pacemaker again, where the atrial chamber is being paced appropriately. There is a P wave and there is a spike which is not capturing the ventricle. So there is a problem with ventricular pacing in both these tracings. So there is no capture. Here is another example where there is complete heart block and in between you can see those pacing spikes which are not capturing the myocardium, which is an example of no capture. The second thing is sensing related problems where you get spikes where you don't really expect them. So you get spikes on the QRS, on the P wave, anywhere. That itself would mean that the pacemaker is not sensing what is going on with the heart. There are times when we get this kind of spikes and they could be just artifactual as well. Even in normal patients you may get just electrical artifacts, not pacemaker patients. You would just get electrical artifacts and you don't know what it is. So some electrical noise or electrical artifacts, or even your ECG lead, if there is a make and break in your ECG lead, it could give rise to artifacts like pacing spikes. So you should just be wary about it. Essentially, spikes at wrong place would mean pacemaker is not looking at what is going on in the heart. You would also get this kind of spikes if somebody has put a magnet on the pacemaker. Or if it is in a non-sensing mode, you could get spikes anywhere. So this is basically, it would mean no sensing. And over-sensing, meaning it is just not giving pacing spikes where it is expected, just like you see in this tracing where you get a sensed P wave followed by a paced QRS on 2 beats, and then 1 beat there is no spike at all, which would mean the pacemaker thought that there is a QRS there for some reason and did not give a spike. Very simplistically I am just explaining it to you. And then there are times when you just get an underlying rhythm which is going on, and then spikes which are independent of that underlying rhythm, which would mean either there is both sensing problem and pacing problem, or both, and which happens very commonly in battery depletion, where initially a dual chamber pacemaker shifts on to a single chamber pacemaker or a VVI mode, and eventually when the battery is completely depleted, it just does not pace at all. Now this is another example of a lead fracture where you are getting independent spikes independent of the rhythm. They are neither pacing or neither sensing. So both is a problem. So if it was just a VOO pacemaker, you can imagine, at least at some points when the spike falls in a period when the myocardium is not refractory, you would get capture. But here you are finding that all the spikes are falling. It's just like an independent pacing spike going on, which would happen if the lead is completely disconnected from the myocardium. So the pacemaker is delivering spike, it is not sensing anything, but it is not reaching the myocardium. So both under sensing and loss of capture. This is another thing, just like what Ashish told, is you get the underlying pacemaker rhythm, and in between you are getting QRS complexes which are not like the paced rhythm, and this would happen in anybody who gets a VVI pacemaker, because there is an independent atrial rhythm going on from the top, and you could get some capture beats or fusion beats. Just like if you have a ventricular tachycardia going on, you say that you could get capture and fusion beats. A VVI pacemaker is basically a slow ventricular rhythm, just like a ventricular tachycardia. So you could similarly get capture and fusion beats in VVI pacemakers. This is another interesting scenario when pacemaker patients, now not seen now because of the advanced pacemaker algorithms, but you may find that a pacemaker is getting paced at a very fast rate. So there is an atrial sensed and a ventricular paced rhythm at a very fast rate near the upper rate for no reason in a resting patient. So if it is persistently there, it is pacemaker induced tachycardia. The current algorithms take care of it automatically. And then we come into pseudo malfunctions in which you get inappropriate lack of pacing, in which the pacemaker is actually trying to look at underlying rhythm in order to avoid ventricular pacing, just like this, in which minimal ventricular pacing modes, this would happen. It's called pseudo malfunction. Or in threshold searches, in which the pacemaker delivers a lower amplitudes impulse and then it follows it up with a higher amplitude impulse to prevent asystole. So it is accidentally captured if at all you are doing, if you have programmed those algorithms at a time when you are going to take the ECG. So this is another example of AV search algorithms wherein you are not getting any ventricular pacing. And then this is an example of crosstalk in which one chamber is being paced and the other chamber is sensing it, which gives rise to asystole. To prevent this crosstalk, ventricular safety pacing is there. So especially if you are able to sense something in the ventricle when an atrial signal is there, the pacemaker will see that, oh, it is too early for the ventricular signal to come after that atrial signal, and it will automatically give in a ventricular output. So to prevent asystole, it's called ventricular safety pacing. Similar to ventricular safety pacing, you have something called as cross stimulation. So the first tracing is very interesting. It is taken from a book only, but just look at that tracing, what that tracing shows, the first tracing. Can anybody just tell me what is happening there? And we had a very similar patient which I lost that tracing when we were in Canada. It was detected on a Holter or a telemetry in the ward. So just look that there is complete heart block, that is for definite. There are multiple P waves, but you are not getting any spikes. Now look at the times when you are getting spikes. The first spike is giving rise to a QRS, right? And the second spike is falling on the refractory period. So you can imagine if the first spike is giving rise to the QRS, then that lead is pacing the ventricle. Now it's very hard to imagine that the ventricular lead is giving the first spike. So most probably what has happened is the leads have been switched on the generator. So they put the ventricular lead in the atrial pacing site and the ventricular lead in the atrial lead in the ventricular pacing site, which is giving rise to prolonged asystole. So the between trace, when there is no spike, all those P waves are being sensed by the pacemaker as QRS complexes. And in the bottom trace, again a atrial lead which has fallen down into the ventricle, you can see that you're getting some spikes which is giving rise to pacing in the ventricle. So whenever you see the first spike giving rise to QRS, just know that there is something wrong with the connections. Now I have a couple of ECGs, we'll just finish with this. Is there a problem with this ECG? Or is it okay? So if you look through it, you are getting two spikes, right? We are able to see two spikes here. So there is an atrial spike and a ventricular spike as well. But the QRS just looks normal, right? It doesn't look like a pace QRS at all. So the reason is this is conduction system pacing. And if you really capture the conduction system well, it will just look like a normal ECG. So I think it will go on and on. Pacemaker ECGs are very, very interesting. This is an example of loss of atrial capture in a conduction system pacing. You get atrial spikes but no P wave, but the ventricular pacing is good. This is an example where there is no atrial sensing, just pacing the conduction system in a VVI mode. This is an example of a normal pacemaker function where atrial ectopics are being sensed and the ventricle is being paced. And this is again an example of minimal ventricular pacing. Thank you so much for your attention. Can we? Yeah. So thank you so much. So can I have my next lecture on also?
Yeah. So Rajesh sir will continue his next topic, that is pacemaker, what is new?
So I'll quickly finish this one also, and I really thank Wasim Rashid sir for allowing me to take his time. So pacemaker ECG is very simple. If somebody has a pacemaker and an ECG, interrogate. If the interrogation is normal and you're getting an abnormal ECG, it would mean that there is some algorithm which is going on. You have to just call the company representative if you cannot understand it on your own, because they know it better and the algorithms also change from time to time. But if there is a problem with the interrogation, then you probably can pinpoint to it. So this is a presentation created by my fellow Sampath Kumar, and this is when last year we did Micra pacemaker. So as we all know, pacemakers are an evolving thing. So a lot of stagnancy was there in the pacing field for quite some time until conduction system pacing, his bundle pacing came in, conduction system pacing came in, and finally leadless pacemakers came in 2016. Approval was received in 2016. Lot of things that can improve in the pacemaker scenario as well. I think now stenting or angioplasty has gone into a stagnant phase, and maybe something comes up in the angioplasty scenario also. But on the electrophysiology scenario, especially in the pacing scenario, these two interesting things have happened. One is conduction system pacing and then leadless pacemakers. As we all know, lead is the weakest link in all our pacemakers, and all issues that can happen is because of the leads. And how beautiful it would be if somebody gets a really very small device which does not need a battery, or if it can be charged from outside, it will be really a very nice thing, which can sense, pace, defibrillate, take care of the heart rhythm all at one go. Then probably as electrophysiologists we can go home and sit and do nothing. So what is leadless pacemakers? So currently we have two systems which are available. They are directly implanted into the right ventricular myocardium. Now, as would with the disadvantages of a RV paced rhythm, you would get disadvantages of an RV apical pacing besides they may not be sensing the atrium also. So thankfully, the current generation of leadless pacemakers, the Micra AV, can actually sense the atrial signals. Now, I would wonder how can a pacemaker lead or pacemaker Micra which is placed in the ventricle can sense an atrial signal. Isn't it? Very, very interesting. So I always felt that, oh, we as doctors, cardiologists are very smart people, but I think engineers are smarter than us. Because they have devised algorithms by which that device can, using the same sensor that is used for rate sensing, they can sense the atrial mechanical systole also. And that too reliably, as much as 70 to 80% of the times, the atrial mechanical systole is sensed by the pacemaker, which can give rise to AV sequential pacing also. So when do we use it? They say that there is no chest scar or bump, but that is not really a reason why somebody would implant Micra. So somebody who gets recurrent infections, both sides are lost or veins are blocked, that is a time when you really need to think about Micra. There are also times when you have patients on hemodialysis, dialysis cannulas, where the risk of infection is fairly high. That is also a time when you can think Micra. And finally, although you can think Micra, the patient should have the money to get that implanted as well. So that is also one of the reasons why Micra is still not in vogue. And last reason is that the battery life also. So it's about 8-10 years in the current generation. The newer generations which will come, which will have a little extended battery life. So, but there are patients where it is really needed and useful and must be used. So the indication, current indication is whenever there is no access, venous access from the top, and in patients who have had previous infections or patients are on hemodialysis. And they say that it may be considered in very old patients because it's a very easy procedure, you can implant it. But I don't know how old is old, because you may always get a patient who lives longer than the pacemaker. So these are the two current generations and their sizes and the dimensions. They're fairly small, but not too small, meaning you can just implant many in one ventricle. The device delivery and implantation itself is also fairly simple. You basically do a RV angiogram using the same sheath and then take the device in and just withdraw the sheath that is surrounding it, and the lead itself and the tines itself, the pacemaker itself will engage with the RV trabeculations. That's how it is done. I just have an experience of one patient which we had done it in a 72-year-old with complete heart block and had CKD. His complete heart block preceded the CKD, about 2 years history of complete heart block, did not undergo anything, and his creatinine had actually worsened. And oh, this is working, videos never work. So we implanted it. One position was not good enough. The high septal position was not good enough in front of threshold. So repositioned it easily and implanted it in a more apical position. As you can see, post-implantation and post-release. So this is how, I don't know if this video will show up. Okay, so this is how it is released. There is a thread which is actually tied to the pacemaker. You just cut the thread and pull the thread back, and it just comes off and it stays there. And this is the ECG. You can see it's a AV synchronous pacing with a fairly narrow complex which is there, and the patient has been doing well now 1 year or so. The thresholds, luckily the thresholds we got were very nice, 0.3 or so. So the expected battery life is 8 years. Otherwise, if the thresholds go up, then the battery life could be a challenge. So this is a new development. Obviously, it's not all good. There could be complications which may happen, and we really need to look at it in a long period of time. The current data is only in terms of implantation success and safety, and that seems all good, doable for most of our patients who need them. So to conclude, leadless pacemakers is something which is useful in a very small subset of patients where it is needed and it can be done, not a challenging thing to do. As times and devices evolve, I think it will be much more easier also. Thank you so much once again, and for giving me a patient hearing for both the talks. Thank you so much. So sensing problems could be because of anything. Sensing problem could be a lead problem or a tissue problem, anything. So right from set screw to your insulation, to your wire, to your tissues where you have implanted it, anything could give rise to sensing problems. And that, how do you identify it? It depends on a situation. Like one patient came in with an ICD shock, and that lady was in Bihar, so she called up. So I said, you go and show a doctor, then I want to come. They came back, interrogated, and there was an electromagnetic interference. On deeper questioning, wherever she was living, there was some big electrical thing which was there, which gave rise to shock. That's all. The device itself was okay. So it could be out of the body and pacemaker also, that sensing issue. So imagine wherever the device is going to sense, it could be. So it could be related to a malfunction of the system itself, or it could be outside also.
Excuse me, sir. Sir, if patient comes for a lead replacement after end of battery life and ask for upgradation and want to keep the battery itself in the position, only changing the leads, is it possible to upgrade from single chamber to double chamber or dual chamber or anything?
As long as the battery life is decent. If the battery life is decent, because whenever we actually do a replacement, we are opening the pocket, and every pocket opening is a potential for pocket infection, which is disastrous. So generally we tend to time whatever we want to do around the time when battery is to be replaced. Thank you so much once again.
Thank you, Rajesh sir. The next talk is by Dr. Wasim Rashid. Topic is how to follow up a pacemaker patient.
Good morning, all of you. So, Dr. Dopesh Walker's talk was the perfect preface to my talk. He showed you what all can go wrong in a pacemaker. So, we need to systematically follow up these patients to detect early the malfunctions and manage them in a timely and efficient manner. So, I'll give you an overview of how to follow a pacemaker patient systematically. So, pacemaker implantation is not only the initial phase in the lifelong management of the patient with a pacemaker. The challenges of this treatment lies in the comprehensive follow-up that this device needs. And as the number of implant devices increase, so does the burden of follow-up. This is made worse by the increasing data provided by devices and the increasing sophistication in programming, therapy, and detection algorithms. But there are certain fundamental principles for pacemaker follow-up. These are evaluation of correct device function and patient safety to national standards. IHRS issued a statement way back in 2012 how to follow up these patients properly. Optimization of system function and maximization of device longevity. We aim to comprehensively troubleshoot pacemaker problems and complications that may arise. It's an opportunity for family and patient support and education. And again, scheduling a next visit for or a device replacement. These are the fundamental principles of pacemaker follow-up. So there are certain basic resources and infrastructure required for pacemaker follow-up. The first thing is technical information on devices and previous follow-up data. Second is an ECG monitor or recorder. Third is an appropriate programmer, of course. Then we need to have a full resuscitation equipment at the place where we perform a device interrogation. Sometimes the device battery is so low that the moment you place a programmer head on the device, it gets drained, and if the patient is pacemaker dependent, he will just collapse there. So we need to have full resuscitation equipment around the place where we are doing a device interrogation. We need to have medical grade pacemaker magnets. We need to have access to database for data collection and retrieval. And above all, facilities to admit patients in the event of an emergency. In terms of human resources, we need doctors, we need technicians, nurses, and industry people to properly follow up and interrogate these devices. The point that I want to emphasize is that anybody who is involved in device interrogations and device follow-up should have a comprehensive knowledge of the programming and various algorithms involved. They should ideally have a credentialing or certification, as is prevalent in Western countries like IBHRE and so on. IHRS took a lead in this direction and initiated a one-year online training program for training and device certification for allied health professionals. So the timeline of a device follow-up can be divided into three phases. The early surveillance period, that is the period from 2 to 12 weeks post-implantation. The maintenance period, and then the intensified monitoring period when the battery is depleted by more than 75%. There have been guidelines on the minimum frequency of pacemaker follow-ups in person or by remote monitoring, which I will talk about briefly. So the first visit should be in person within 72 hours of the pacemaker implantation. The second visit, again in person, should be at 2 to 12 weeks post-implantation. Then we can follow up in person or through remote monitoring every 3 to 12 months, depending on many factors. And an annual in-person visit should be done for battery depletion. When there are signs of battery depletion, the device interrogation is more frequent at 1 to 3 months intervals. There are instances where we need additional clinically indicated pacemaker checks. For example, if the patient is getting admitted for some other medical reasons, if he's going for an MRI, if he's going for radiation therapy, if he's going for a surgical procedure, or when device information is needed for clinical management like investigation of syncope or optimization of heart failure treatment. So many factors determine the frequency and the type of pacemaker checkup. This may be patient-related, device-related, or disease-related. So what minimum information we should get when we interrogate a pacemaker? The 4 things are very important: pacing lead impedance, sense P and R wave amplitudes, pacing thresholds, and battery voltage and impedance. This is a more comprehensive list for a systematic pacemaker interrogation. First is the clinical examination of the patient and history, and evaluation of the wound site during in-person checks. Then Medtronic has developed this acronym, which I like. It's a very useful acronym for a systematic device interrogation. It's called PBL STOP. P stands for presenting rhythm, rate, and pacing percentage. B for battery status. L for lead status. S for sensing. T for threshold. O for observation, events, diagnostics, trends, and all that. And finally, we need to program the device and print a detailed report. It's recommended that all institutions have a device follow-up form for every patient that is interrogated. This helps in patient management, follow-up, research, as well as for medical legal purposes. This is a sample from Medtronic. As the technology has evolved and the wireless monitoring has become a sizable part of the CID follow-up, with evidence demonstrating its safety and feasibility. Advantages of remote monitoring include timely detection of actionable events, such as device dysfunction and cardiac arrhythmias, with mortality benefit demonstrated in some studies. Convenience and improved efficiency are further potential benefits. However, even in developed countries, it's a time-consuming process and requires substantial administrative and technical support. In India, it is prevalent in some metros, but the comprehensive infrastructure that it needs for handling the data that is generated through these devices is still not there. But in future, it will certainly become integrated in the follow-up of these patients. BHRS has given a hybrid model of in-person and this remote monitoring, and I think this is very pragmatic. So they urge the patient after 2 to 12 weeks to enroll in remote monitoring, and if he's remote monitoring compliant, if his auto-threshold testing and trends are normal, if his EGM, which pace and sense function is normal, and my patient is clinically stable and device is stable, he continues to do a remote monitoring, but comes for annual in-person checks. If any of them is not there, then he goes for an in-person check. There are special situations that may arise during the lifetime of a patient who has a device implanted. These include electromagnetic interference. This is an important issue, and common sources are unipolar electrocautery, MRI, electroconvulsive therapy, lithotripsy, therapeutic radiation, transcutaneous electric nerve stimulation, and defibrillation or cardioversion that the patient may need. Then there comes the issues of perioperative management, MRI, and hazard alerts and device recalls. Briefly about perioperative management, if the surgery site is below the umbilicus and the only monitoring is required, no reprogramming is required. But if the surgery is above umbilicus and the patient is pacemaker dependent, we should consider reprogramming to fixate the rate and if prolonged diathermy is anticipated. For electroconvulsive therapy, lithotripsy, we should interrogate the device within 1 month after treatment to see if any parameters have been changed, and we should try to avoid lithotrip during, near the pulse generator. Same holds true for nerve conduction studies. You might need to reprogram. For endoscopies which use argon beam and, or diathermy, again, pacemaker-dependent patients should be reprogrammed to a fixed rate. This is an example of how to apply cardioverter patches in a patient who has a device implanted. It should be the anterior-posterior position, at least 6 inches away from the device. Patients who have a device implanted and have to go for therapeutic radiation represent a complex bunch of patients, and sometimes if the site of the malignancy is too close to the, we might need to relocate the programmer, relocate the device, I mean. And we have to have proper dosimetry, and if the radiation dose is more than 5 grays, then we have to follow up these patients very closely and monitor them very closely during their therapy. Finally, devices are subject to manufacturing defects, and if this happens in a significant number of devices, in a batch of devices, the company itself calls them back, which is called a recall. And if you encounter a manufacturing defect in a device which you have implanted, the first thing is to see what kind of a malfunction it is. Is it a high-risk malfunction which has a reasonable probability that device fault will cause serious adverse consequences or death? Is it a moderate risk which will cause temporary or medically reversible adverse health consequences? Or if it's a low risk which can be managed by adequate programming and troubleshooting? So we have to report them, and in consultation with the manufacturer, we have to sometimes even replace these, the leads or the generator. So to summarize, device follow-up should only be performed with appropriate infrastructure and trained staff. Main aim should be to ensure appropriate safe device function, tailored to the individual and to meet national standards. Personnel performing follow-up should have a comprehensive knowledge of the advanced features of the individual cases, and care pathways should be in place to manage pacemaker-related complication and device advisories or recalls. Thank you.
Any questions for Dr. Wasim, sir? Thank you, sir. Thank you, chairpersons. We now move on to the didactic lectures. May I request the next set of chairpersons, Dr. S.N. Kore, sir, Dr. Manjari Dhamangaonkar, madam, Dr. Yogesh Somani, sir, and Dr. Nilima Deshpande, madam. You are requested to join the dais. And we begin this session with a talk by Dr. Dayanand Kumbla, sir, and his talk would be on ambulatory ECG.
At the outset, let me thank ISECON and Dr. Gurunath Parle
Dr. Karvekar, sir, also is requested to join the stage.
For having invited me to give this talk
Dr. B.M. Karvekar, sir,
on ambulatory ECG monitoring. We are lucky to have come here in the pious city where we could see Pandharpur. Ambulatory ECG monitoring. All these days we had ECGs, then there was digital transformation of ECG through the trans-telephonic way, and today we can transfer the ECG by WhatsApp itself. If somebody has taken an ECG and you want to make a diagnosis of acute myocardial infarction before thrombolizing him or before doing any PAMI, we can WhatsApp those ECGs and that can be sent to the center for further management. Now my pictures are all these old pictures, old string galvanometer electrocardiograph showing the big machine with patient rinsing his extremities in the cylindrical electrodes filled with electrolyte solution. This tracing shows first human electrocardiogram recorded by Augustus D. Waller of St. Mary's Medical School, showing simultaneous electrometer and cardiograph tracings showing an electrical activity preceding every heartbeat. This is how the ECG evolved. Now, going back to the history, timeline of clinically pertinent landmarks in the development of EKG, acknowledging the important efforts of other scientists in this process. So everyone knows William Inthone, who discovered ECG. So right from 1842, recorded electrical activity from the heart of a frog. Then Waller recorded first electrical activity from the human heart. Then Inthone was the first use the term EKG. So many of us, either we use ECG or you use EKG. Inthone built string galvanometer based 3-lead EKG machine. Then EKG entered the US, then you had Inthone received the Nobel Prize for this. Wilson invented the central terminal precordial leads were born. Then Goldberg used the central terminal. Then AHA standardized the 12-lead EKG as we now regularly use it. Ambulatory ECG monitoring, when it has to be used. Typically used to evaluate symptoms such as syncope, dizziness, chest pain, palpitation, or shortness of breath, which may correlate with intermittent cardiac arrhythmias. So many patients come to us with syncope, chakkar yevangeli, for how long we don't know. So all these patients, one can hook them to this ambulatory ECG monitoring to find out what was the cause of the dizziness or syncope. Additionally, to evaluate patient response to initiation, revision or discontinuation or arrhythmic drug therapy, and to assess prognosis in specific clinical context. Even in a patient who has just recently had a myocardial infarct and is discharged, one can risk stratify whether he is getting malignant arrhythmias by hooking him to this ambulatory ECG telemetry. Ambulatory monitoring capabilities, what all does it do? ECG, heart rate, arrhythmia, blood pressure, cardiorespiratory fitness, stress, respiratory rate, temperature, oxygen saturation, ischemia, and apnea. So many tests an ambulatory thing can monitor. So devices for ambulatory monitoring are plenty. Wrist watches. Nowadays we have patients who have smart watches and they come and show us that my particular heart rate was very fast. This is what I recorded on my wristwatch. So we have smartphones, patches, headbands, eyeglasses, necklaces. Initially when smartphones or these mobiles came, we only used it for speaking to somebody or receiving telephone line. Now that we are using it as a computer itself, so we have a computer in our pocket and one can really track a patient or track a person anywhere in the world. Indications for ambulatory electrocardiographic devices like unexplained palpitations, unexplained syncope, cryptogenic stroke. So many patients who come with TIA and then they recover totally. In them also it is worth doing a ambulatory ECG monitoring to find out whether he had a transient episode of atrial fibrillation. After that, one subjects them to transthoracic echocardiography to find out if there are any clots. If you are still not happy, one can go ahead and do transesophageal echo and detect any intramural clots. Prognosis in hypertrophic cardiomyopathy, so many people move about with HOCM. In them also you can risk stratify them by hooking them to this ambulatory ECG monitoring. If he has some malignant arrhythmias, you can suggest him a pacemaker. Arrhythmogenic right ventricular dysplasias, again the same thing. WPW syndromes, patients who present with palpitations. You have a ECG in your consulting room where a patient has WPW syndrome, but when you interrogate him, he says, sometimes I get palpitations. So these are the guys who you can subject them to ambulatory ECG monitoring. Arrhythmia treatment assessment. The patient is already having atrial fibrillation, he is controlled, so you can again hook them to the ambulatory ECG monitoring, and even other arrhythmias where the patient is on treatment, you can find out how effective is the treatment. So pill in the pocket after antiarrhythmic therapy and post-ablation as well. Types of ambulatory ECG monitor currently available in clinical practice. It's like stents, we have the same way ambulatory ECG monitoring, first generation and second generation. First generation, patient wears a monitor for 24 to 48 hours and ECG is recorded. Then we had the event monitoring facility where patient has a device and whenever he has any symptom, he'll just press the button and that event will be recorded. Or loop monitoring. Again, loop monitoring, the device is hooked to him for nearly 30 days. So he has the chest leads with the monitoring device. Second generation external ambulatory ECG monitoring where we have the Holter monitoring. So patches are available. The various patches like 48 hours, 72 hours, 7 days, patches are available, which is very easy. Just a patient, this particular patch is applied on his chest and he goes about. Initially, they used to advise the patient cannot take bath on that. Today, they advise patient can take a bath, can go for a swimming as well. Ambulatory telemetry monitoring, that was in the hospital, you can put a patient on ambulatory telemetry monitoring and record his ECG. Challenges associated with ambulatory ECG monitoring, patient compliance, skin irritation. That electrode which you place for 24 or 48 hours really irritates. And even those patches, when the climate is humid, many a times you have to have an additional adhesive tape to really fix that patch. Artifact interference, data analysis and interpretation, and limited monitored duration. Somebody has palpitation once in 15 days and you have hooked him for this ambulatory ECG monitoring, that may not go on a record and he will say unnecessarily I have spent the money for 2 days wearing this particular gadget. Ongoing advancement in technology and improvement in monitoring devices aim to address some of these challenges and enhance the diagnostic capabilities of ambulatory ECG monitoring. Ambulatory ECG devices, traditional Holter monitoring, 24 to 48 hours, patient applies then, goes home. Event recorders, he has got in his pocket one event recorder. Whenever he gets symptoms, he'll just press it. External loop recorders are like Holter recording itself and that can remain for 30 days. Only problem is the skin irritation which people can develop when you use that electrodes for more than 3 or 4 weeks. Implantable loop recorders. This is another thing where you put that implantable loop and it remains in the body for maybe for 4 to 6 months and it can keep on recording your ECG. Mobile cardiac telemetry, leadless wireless ECG patch, Cardia Mobile, which we can get in our mobile itself, ECG can be recorded. Apple Watch Series 4 records our ECG and gives us what is going on that patients can wear and tell us. Holter monitoring is 1 or 2 days, ease of precise quantification and familiarity, retrospective, disadvantage being retrospective and short duration. Event monitor is 1 to 30 days, ease of use, patient activation, skin electrodes, high failure rate because of the skin gets irritated. External loop monitors, implantable loop monitors are good, which can be placed indefinitely, long period of observation, no skin electrodes. Patient activation and invasive, only thing it is an invasive procedure. If somebody has got a pacemaker, it can be definitely interrogated and to find out what are the arrhythmias going on. Hospital telemetry or outpatient telemetry. Now what is the yield of various modalities? Event recorder, duration of recording is just 60 seconds. So palpitation yield will be 50 to 60%. Syncope not applicable. A person has a syncope, I don't think he will be in a position to start that event recorder. So if a person has palpitation, he can start that event recorder and that thing can be documented. Standard electrodes, standard Holter monitoring, or somebody wearing a patch, 1 to 4 weeks of ELR and ILR, implantable loop recorder, which may go for more than 3 or 4 months, but there the yield of palpitation will be around 80 to 90%, syncope around 30 to 50%. Now various recommendations in class 1, all those various indications is a very boring thing, class 2A, then Key advantages of ambulatory monitoring, prolonged monitoring, real-time recorded during daily activities, increased diagnostic yield, patient convenience and compliance, evaluation of treatment efficacy, correlation of symptoms and events. Thank you. Dr. Gurunath is called Lord of Teachers. He has really taught everyone over here. Thank you very much.
Thank you, sir. I now welcome the next speaker, Dr. Ketan Mehta, sir, and he will be talking on ECG in pulmonary disease. Sorry. Before that, I just want to request Dr. Kumbla, sir, and I request the chairpersons to felicitate him.
A long refractory period.
Thank you, sir.
Good afternoon. No, it's still good morning. In fact, I was supposed to talk in the afternoon. And thanks to Dr. Parale for shifting the position and Dr. Rituparna Sinde. At the onset, again would say thanks to Dr. Gurunath Parale for an excellent arrangements for this ISECON, midterm ISECON 2023. And my dear friend, Dr. Rituparna has shifted this. Friends, I am going to talk about ECG in pulmonary diseases. You have been talking about and hearing about ECG in cardiac conditions so frequently since last 2 days, but my subject is little bit different, and that is so much relevant, especially. The bottom line is that ECG is not just for cardiac conditions. We need to take care of extra or known cardiac conditions, and which is we know that cardiopulmonary system is so much interrelated. Increase in pulmonary pressure will eventually affect the heart, which we know, prominently right ventricle, and changes in left ventricular pressure will affect the pulmonary system. So it is so closely related, which is going to reflect in ECG changes. So let's start with this case. This is a 23-year-old man who is brought by paramedics after an episode of syncope at home. On arrival, he is with severe respiratory distress, extremely pale, dripping with sweat, BP 125/70, heart rate of 80 beats per minute, tachypneic respiratory rate of 40, SpO2 95% on 15 liters oxygen, and his chest X-ray, which was done at that point of time, is normal. And this is the ECG, which is done in ER, which is what is showing. Anybody quick, the students, postgraduate students are here. The diagnosis or suspicion of anybody? Young boy, not having first episode of syncope, severely tachypneic, X-ray chest is normal. Okay, there you are. So here you have a sinus rhythm with left axis deviation, right bundle branch block which is present. There is a right ventricular strain which is present here. And then if you see, there is a widespread ischemic changes also which will present. So somebody will label it as ischemia and would add. So now this is, as rightly said, is acute pulmonary hypertension secondary to massive pulmonary embolism. What is important to understand, those ischemic pattern which you get is because of the severe global tissue hypoxia which results from obstructive shock and hypotension, and as a result of which you will get associated diffuse STT changes also. Now, point to be remembered for pulmonary embolism that ECG changes are neither sensitive nor specific to diagnose or exclude pulmonary embolism from ECG. 18% of patients with pulmonary embolism will have a completely normal ECG. So that is a point to be taken care of. Now, what are the changes which can be seen in pulmonary embolism? There would be a sinus tachycardia, there can be a right ventricular strain pattern, there can be a right axis deviation, There can be a dominant R wave in V1, so we know it is right ventricular preponderance, right atrial enlargement or P pulmonale which can be seen, clockwise rotation which will be seen, various atrial arrhythmias which could be atrial fibrillation, atrial flutter, atrial tachycardia, and as I mentioned, non-specific STT changes which can be seen over there. Now, this concept which all of us have learned right from our undergraduate then, S1, Q3, T3, you know that if you see this pattern, it is highly suggestive of pulmonary embolism. Yes, let me tell you over there, this S1, Q3, T3 is a short-lived and it resolves within the 2 weeks after the pulmonary embolism. It is neither sensitive nor specific. It is found in only 20%. So, you know, if you don't see this pattern prominent S in lead 1, Q in lead 3 and the T wave inversion in lead 3, doesn't exclude it. Of course, in clinical setting, if you have this pattern, you will definitely suspect that there could be a pulmonary embolism. It is found in only 20% of patients with pulmonary embolism. Now, there is a ECG scoring system of pulmonary embolism, and there are various scores which has been given. So, you know, tachycardia, incomplete RBBB or complete RBBB, T-wave inversions in V1 to V4, and again in that T-wave inversion, the scoring system has been given, and then you do the total scoring. Maximum points are 21, score more than 9, which suggests pulmonary embolism. So this is a point which needs to be taken, to be kept in mind. Now, next come to COPD. Of course, the COPD, of course, you are not going to diagnose from ECG, but there are ECG changes which occurs due to the hyperexpanded emphysematous lungs and hypoxic pulmonary vasoconstriction. Now, various ECG changes which can be there. Somebody who is brought to the ER with acute exacerbation of COPD, this could be a ECG of that patch, where it could be a rightward QRS axis. If you see, there is a peaked P waves in inferior lead, so like a P pulmonale in lead 2, which is seen, clockwise rotation, absent R waves or poor progression of R in precordial leads, what has been described also, and the low voltage in left-sided leads, that is in lead 1 AVL, which can be seen. And of course, you will have a SV1, SV2, SV3 pattern as I was mentioning. Multifocal atrial tachycardias or MAT, which is defined, all of you know, that atrial tachycardia with an overall rate which is greater than 100 with distinctively 3 different morphologies of P waves. And this is again very classical suggestive of that could be underlying pulmonary issues also. Then there are Chow's ECG criteria for COPD, and which all depends on the P wave and QRS wave. So you have a P pulmonale and P wave axis of plus 80 degree, and the QRS criteria, QRS amplitude less than 5 millimeter in limb leads, QRS axis plus 90 degree or more, QRS amplitude less than 5 millimeter in V5, V6, S1, S2, S3 pattern. Again, that means we had seen that, and atrial arrhythmia. So COPD is likely if there is a 1 P criteria and 1 QRS criteria is present. Core pulmonale, again, once the patient has got advanced COPD going into core pulmonale, there could be a right axis deviation, the right-sided preponderance which will be there, P pulmonar pattern. S1, Q3, T3 can also be seen in core pulmonale also, and the overall low voltage which is seen. So again, this is a patient with a core pulmonale with COPD with right axis deviation, right ventricular hypertrophy, RV strain, and incomplete right bundle branch block. Now again, the patients of this COPD can have the, as I told you, atrial arrhythmias because of the primary condition, and the drug therapies used, they have ventricular arrhythmias, premature ventricular complexes can be unifocal, multifocal, which can be seen on that. Now, this is another case, 44-year-old male developed severe chest pain and dyspnea while jogging and presented to ER. Had he, we don't know, sometimes people are just say, oh my God, there are some STT changes, are there, take him up for an angio or anything. Assessment, X-ray was done, and he had something on X-ray. Can anybody suspect what could be the probability? Pneumothorax, right? And this is the same patient after the ICD insertion. The ECG changes the voltage, which was, if you see, that drastically it has changed after putting a ICD tube, and patient got relieved of his symptoms. So again, ECG changes does not always mean it is a cardiac condition also. And this is the last case, a 52-year-old male diabetic had acute febrile illness for 4 days, progressive worsening of breathlessness, presented to casualty with tachycardia, BP 112/74, tachypnea, and with hypoxia, saturation of 85. ECG done at that time was showing this type of pattern. Anybody? What could be your suspicion? Acute febrile illness, short history, tachypnic. Yes, and in the current time, he turned out to be, of course, this is during the COVID time, he was COVID-19 positive. So various ECG changes have been described in COVID-19, which is attributed to hypoxia and inflammatory damage, which is caused by the virus itself. So ECG changes known over here could be sinus tachycardia, various arrhythmias, new onset atrial fibrillation, myocardial ischemia that has been found over there. Now, this patient, there have been seen at same time patients who were put on HCQS and azithromycin at that point of time. QT prolongation, which was known, which was also found in so many of patients. So, ladies and gentlemen, to summarize, ECG, which is a simple test, which we do it routinely for cardiac conditions, but which will add value for pulmonary diseases also. Of course, you are not going to diagnose a single pulmonary disease from ECG. It would be suggestive of it. Additional X-ray chest. So patients of breathlessness and chest pain do get the X-ray chest done, which will add value to it. Thank you so much for your patient hearing on this. If there are any questions, would be happy to answer.
Okay, thank you, sir.
Thank you.
I thank all the chairpersons. We now move on to the next two talks. Thank you, chairpersons. Thank you for chairing the session. And there is an announcement that as some students have to travel back, so we are preponing the award valedictory function, which will be held after the next two talks. Awards will be given away by Dr. Palle sir, Dr. Singhal sir. The next set of chairpersons I would like to invite Dr. R.K. Joshi sir, Dr. Vinay Kumar Bhopatkar sir, and Dr. Vinod Bohra sir. Please join the stage. And for the talk, I invite Dr. Ajit Bhagwat sir, senior cardiologist. He would be talking on antiarrhythmics other than amiodarone.
Good morning, everybody. First of all, I would like to thank Dr. Parale, Dr. Nabar, and Dr. Rutuparna Shinde for allowing me to switch the talk. I'm speaking ahead of my turn. And I would also like to congratulate Dr. Parale for organizing this wonderful meeting. And it's very rare to see such a scientific program which kept everybody riveted to their chairs, not only yesterday but this morning also. And it was also very heartening to see that he is in this hall almost throughout this scientific program, and that showed his commitment to the program. So I would like to congratulate him again. Now, I would like to speak on antiarrhythmics other than amiodarone, and we had some discussion on this topic yesterday. So, all of us know this Vaughan Williams classification of antiarrhythmics. Class 1 are sodium channel blockers, class 2 beta blockers class 3 or potassium channel blockers are class 4 or, class 2 or calcium channel blockers and class 4 are beta blockers. Now, amiodarone is a drug which is often misused, abused. And the reason is, we had some talk about it yesterday, occasional PVCs, atrial ectopics, these are very commonly seen indications where it is used without a very strong indication. Another area where I see this being used is chronic persistent AF. The patient continues to be in AF for a long time and patient continues to be on amiodarone. Actually, amiodarone is to be used for suppression and conversion of atrial fibrillation to sinus rhythm. But if patient continues to remain in atrial fibrillation for months and years, there is no need to continue this patient on amiodarone. And before we switch to the other drugs, we need to know what are the side effects of amiodarone. And all of you know that corneal microrethiasis is seen in 90%, thyroid dysfunction, pulmonary toxicity, skin discoloration, and peripheral neuropathy. But what are the strengths of amiodarone? It rarely kills the patient acutely. It doesn't have pro-arrhythmic effects. It prolongs QT, but torsade is very, very rare. It can be given to patients with structural heart disease, more effective than its competitors in suppressing AF, VTVF, and PVCs. And it prolongs QTC, but torsade is quite rare. Before we discuss other antiarrhythmics, we need to know what is structural heart disease. One is large myocardial scar, significant LV dysfunction, severe coronary artery disease and active ischemia, and severe valvular heart disease, causing LV dysfunction, of course. And these are the indications. What I would do is, I would just enumerate the indications of amiodarone and then discuss the other drugs which can use for these indications. So, termination of AF, maintenance of sinus rhythm after AF, termination of sustained VT, suppression of VT-VF in patients with ICD, treatment of other SVTs, and use of amiodarone reduces ICD shocks and reduces the requirement of catheter ablation. Now, these are the indications of amiodarone. Treatment and prevention of sustained VT, the choice, particularly after infarct, the choice is IV lidocaine. Treatment of AF for conversion to sinus rhythm, where we use IV amiodarone, you can use IV ebutalide or pill in pocket, which is either flecainide or propafenone. Maintenance of sinus rhythm after restoring sinus rhythm from AF or atrial tachycardia, the choice is sotalol, propafenone, and flecainide. So this is type 3 and this is 1C. These two are 1C. And suppression of VTVF and PVCs, the choice is sotalol, propafenone, flecainide, and beta blockers. So let's start with lidocaine, which we used it when we were residents, or fellows during our time. And this is a good drug which has to be given in bolus dose followed by infusion. And if you give it, it achieves a sustained level pretty quickly. Should all patients receive lidocaine post-MI, as we were taught during our residency fellowship days? The answer is clearly no. 20 randomized trials and 4 meta-analyses have revealed that although lidocaine reduces VF, it increases mortality by inducing bradyarrhythmias and asystole. So when should it be used? When multiple PVCs or tachyarrhythmias result in hemodynamic compromise, post-MI, during cardiac surgery, or during general anesthesia. So you can use it. It should not be used in a setting of bradycardia when pacing is preferred. So post-MI, its routine use is certainly not recommended. What about ebutalide, which we had some discussion on yesterday? It's used intravenous. Its efficacy is as good as amiodarone in AF and atrial flutter. 1 milligram IV infusion over 10 minutes. It prolongs QT, and the prolongation is maximum at the end of infusion, and it returns to normal in about 1 to 2 hours. Torsade is seen in 4.3%, most common within 1 hour of infusion, and observation is must at least for 4 hours, but it's safer to observe this patient for a day, so better to admit them. 4.3 is not a very small number, so one must be very, very careful. Give magnesium as default to these patients, 3 to 4 grams, and watch their QTC. Avoid ebutalide in patients with prolonged QT, hypokalemia, and in patients with advanced heart disease. But I've used it in quite a few patients. It's very good. I would say that it has worked in at least about 80% of the patients where I have used it when the atrial fibrillation is of very short duration. What about flecainide and propafenone? These are type 1C drugs, and these were the villains of CAST trial, which was published in early 90s, which killed patients post myocardial infarction with PVCs. So flecainide and propafenone both are described in pill-in pocket for conversion of recent onset AF. They must not be used in patients with structural heart disease, as it was shown with CAST trial, where the drugs which were used were incanide, flecainide, and morisizine, out of which incanide and morisizine are gone. Proarrhythmia, it's a problem, causes incessant VT. It's a good alternative to amiodarone for prevention of AF, flutter, and SVT. One must make sure that there is no structural heart disease when you are using these patients. So this is most important message you can take from this talk. Oral maintenance therapy is required after this, and always use an AV nodal blocking agent when used in treating SVTs, because of such a situation, what happens is when atrial rate is very fast, and if you use 1C agent, it slows the atrial rate, and sometimes it results in one-to-one conduction, resulting in very fast ventricular rates. So if you use AV nodal blocking agents along with this, it's very useful. So last few words about sotalol. Now this is a beta blocker, but it should not be used as any other beta blockers, because this is a double-edged sword. It has got class 3 properties. It's a class 3 antiarrhythmic agents, prolongs repolarization, and always fraught with problems of torsade. It is used in prevention of AF and atrial tachycardia recurrences, prevention of VTBF recurrences, WPW syndrome. These are some indications. Its efficacy is as good as in other type 1C agents. Dosages, you can always look it up in the books. Dose is 160 to 320 milligrams for SVT and 160 to 640 milligrams for VT. But doses above 320, you must fear about torsade in such patients. So avoid doses more than 320. It is contraindicated in patients with eGFR of less than 40. QTC more than 450, you should avoid it. This is in its package insert. It is not to be used in combination with the amiodarone. Amiodarone and sotalol combination can be lethal, and incidence of torsade and sudden deaths goes up. Avoid it in patients with very severe LV dysfunction. So proarrhythmic effects, as I mentioned, class 1C agents, they produce unidirectional block, re-entry circuits are induced, and it can result in incessant wide complex ventricular tachycardia. And this probably resulted in increased number of deaths in CAST trial when these agents were used post-MI in patients with PVCs. So they eliminated PVCs, but they also eliminated the patients. So not to be used for post-MI PVCs. And class 1A, 3 agents, they can induce triggered activity and torsade. So in summary, amiodarone is a very useful drug in prevention and treatment of VT and SVT. It is abused frequently and is associated with serious side effects with long-term use. Alternatives to amiodarone are available. However, one must be aware of the nuances associated with their use. Thank you very much.
Okay. Thank you, sir. I request Dr. Machnurkar, sir, to join the dais, please, as a chairperson. And I request Dr. Rutuparna Shinde, sir, to take over the next talk. His topic is QTC revisited, QT interval revisited. Dr. Machnurkar, sir.
Thank you very much, organizers, and indeed I would like to thank the organizing committee of Midterm ISECON 2023, Dr. Gurnath Parale and his team for an excellent conference. A person like Sam Asirwatham came all the way from Rochester, Minnesota, in a place which does not have an airport, and stayed here for the whole day, and that is a big achievement. Give a round of applause for Dr. Parale and his team, please. I mean, I'm going to next 10 minutes discuss with you a very small but very important topic, that is the QT interval. In the era of COVID, this has come into light because of the use of various drugs, and my things have been made a little simple by Dr. Ajit Bhagwat. So before starting this, I would like to show you these 4 ECGs. These are wonderful ECGs. Out of these, 2 are LQTS and 2 are normal. Just make a visual note. We'll discuss this at the end of the talk. So coming to QT interval, we all know QT interval is the measurement starts with the start of the Q wave or the R wave and ends with the T wave. But there are various issues associated with QT interval which makes us a little wary of calculating the QT, that is the QTC and other things. So let's see. Various problems are there with QT. We need to adjust it to the heart rate. We need to see what are the leads in it. If this is the ECG of a QT prolongation, you don't require any Bruhaspati to diagnose that QT is prolonged. Almost the T wave is going into the next P wave, and it's very obvious that it's a very, very long QT prolongation. But we do need to correct it for QT's heart rate. And that is where the Achilles heel of QTC, because we had to run for calculators with square roots and all when we were in MD. And that used to prevent us from calculating QTC. Nowadays, we have apps where you just enter things and you have the corrected QT by various formulas, Bazet, Fredericia, and so on and so forth. So the normal range of a QTC in a male is less than 430 milliseconds, and in a female, 450. 470 and 450 are above normal. In between is the borderline zone. But remember, this QT correction is not very accurate at the extremes of heart rate. So what do we need? We need nomograms like this to help us for calculating QTC. Also, when there are children, we make use of these nomograms. So one of the most important things while calculating a QT is how to correctly find the end point of the T wave. And that is where various maneuvers have been described. First of it called as teach the tangent. That means you take a tangent on the descending limb of the T wave and make it meet the isoelectric line. Where it meets the isoelectric line, that is end of your QT. This is very important because few millimeters here and there can make a huge difference between your QTC. And that is why this tangent, and there are various other methods also which are described, threshold method, derivative threshold, and so on and so forth. We will not get into details of those. And these are the ECGs which actually illustrate how do we calculate the QTC with the help of this tangent method. This is the ECG. Do we really need a heart rate correction? No, we do not require heart rate correction because the heart rate here is 60, and for 60, QTC is equal to the QT what you calculated. Which leads you look after, what to do? Normally when you don't see a T wave properly and you just draw a vertical line on the ECG and see where the T wave falls in the other leads. And if some lead has got a good T wave, you can measure that. And this is how you can make use of the tangents. Another problem with the QT prolongation is to include U wave or not. You see, sometimes in some leads there are distinct U waves and sometimes bifid U waves. So the rule is, if the U wave or the second peak of the T wave is more than 50% of the amplitude of the first T wave peak, it has to be included in your QTC calculation. If it is distinct or less than 50%, you leave it, do not include it. This is again illustrated by these ECGs. First, upper ECG, physiological UAO, distinct, do not include. Second is a typical of LQTS, bifid, camel hump, you have to include that in your measurements. So which leads do we see? So normally leads 2, V5 and V6 are the ones which are having classical T waves, but as illustrated in the ECG downstairs, sometimes you don't see a T wave in these leads, but then whichever lead has got a clear-cut T wave, as in this case V2, you have to correct. What happens when there is atrial fibrillation or irregular rhythm? So there are 2 approaches here. Either you measure 10 separate QTCs for 10 consecutive beats and average them, or you take the longest and shortest RR interval and subsequent QT. So always remember, whenever you are calculating the QT, the RR interval has to be the one before that and not after that. So this is the commonest mistake we made. Whenever you are measuring QT, the RR interval has to be calculated for the preceding beat. And that is very, very important because this QTC is the function of the earlier RR interval. Whenever there are, and that is why whenever there are pauses on the ECG, after say VPB or APB, do not include that particular beat into the calculation of QTC because there are always some T-wave changes following a compensatory pause. We have all been taught that if you fold the ECG on 2 R waves and your T wave falls into the second half of the R wave, it is usually prolonged. Yes, it is true. As a rule of thumb, it is a good way to look at. But again, at extremes of rates, this is not correct. As illustrated here, the first one, QTC is 512, it is less than half of RR interval, yet it is prolonged. And the lower one, it is falling into the second half of the RR interval, yet it is normal. So again, it underlines the fact that you have to calculate it very carefully. What happens when there is a wide QRS or a bundle branch block or a pace rhythm? Then you have to measure what is called a JTC, junctional. So J point to the T's end is to be calculated, and this JTC is calculated as 355 or 372 in males and females. There are other formulas which correct for the width of the QRS. Those also, if you are interested, you can do that. There are various algorithms which have been proposed. This one is by Mike Ackerman in Mayo Clinic. This was proposed during the time of QT COVID. Another thing, do not stop at measuring the QT interval, just look at it. So not only the amount of QT, but the morphology of QT is important, as said by Peter Schwartz, who is the father of LQTS. And in fact, indeed, a morphology of QT prolongation can actually predict a genotype of LQTS. So there are various LQTS, classical QT prolongation. So a lazy wide-based T wave is classical of LQTS, and LQT2 has a camel hump bifid T wave. So there are various morphologies wherein you can actually judge the genotype also, and that's because of various channels and the subsequent channelopathies. In fact, this is a topic in itself. We will not get into the details of that topic, and next 5 minutes or 2 to 3 minutes we will go into some illustrative cases. So this is a 24-year-old HIV positive patient treated by protease inhibitors. Somebody puts him on erythromycin, he gets a syncope. Very classical drug-induced QT prolongation. You look at the leads V2, V3, there are wide-based T waves. So this particular QT prolongation is not because of extension of the ST segment. This is because of widening of the T wave. And we'll come to that. What do I mean? That this type of QT prolongation is more ominous. This is not benign. This is very much prone for torsade SD point test. So this is how it is calculated. You have a QTC of 610. What happens whenever the T wave prolongs? The vulnerable period for the T wave in the T wave, which is got a very low fibrillatory threshold, also increases. The chances for early after depolarization, and if there is a R-on-T phenomena to induce ventricular fibrillation or TDP, are very high. So wider the T wave, dangerous the QTC. In another few seconds, what is the treatment of TDP? The treatment is make the heart rate fast. Put in a temporal line, overdrive, make it fast, your QTC will decrease. You put them on inotropes, you put them on isoproterenol, QTC will decrease. Or stop the drug, give magnesium, and in last case, give lidocaine or mexiletine. This is another case where there is a history of thyroid resection and the patient comes with syncope. Look at the QT interval in lead 2 and lead V5, V6. It is prolonged, but it is not prolonged because of the widening of the T wave. It is prolonged because of the widening of the ST segment, and this type of ST segment widening leading to QT prolongation is usually metabolic, less serious or relatively benign. You correct the metabolic abnormality, this QTC comes back to normal. Obviously, this gentleman had a hypocalcemia which was corrected. So this is a ECG which I want you to remember from this particular lecture. First, on the left hand side is delayed repolarization, extension of the ST segment leading to QT prolongation, relatively benign, metabolic causes. But the other one on the other side, wide T wave prolongation, this is prolonged depolarization, phase 2 potential is delayed, very good chance that this gentleman will get into TDP or ventricular fibrillation. This is another one with 28-year-old male presenting with syncope. Look at lead V5 and V6. Very broad, lazy upstroke of a T wave, classical of LQT. Another one, history of epilepsy in childhood and history of sudden cardiac death in family. Epilepsy in childhood usually sometimes is cardiac, you're already being treated by neurologists, but then if you look at the ECG, if you have time to look at the ECG, you will see classical camel hump T waves in lead V2 and V3. This is classical LQTS, and this requires ICD and not anti-epileptics. There are various LQTS, along almost 13, 14, which have been described. Various triggers are there. Some get triggered by the auditory, some get triggered by pregnancy, some get triggered by swimming. But again, the total thing is out of the scope of this particular talk. It's a topic in itself. But coming back to the first ECGs. These were the 4 ECGs, and these are famously known in the literature as Wiskin ECGs. Sami Wiskin from Tel Aviv, Israel, actually did a study in 2005 and sent these 4 ECGs to, mind well, cardiologists, medical students, and physicians. And this was the conclusion of this particular topic. Most physicians, including cardiologists, cannot accurately calculate a QTC and cannot correctly identify long QT. So who are we? That is what the precise reason why I took this lecture, that we need to address this QTC very well. We have to do the correction. We have to take into consideration various issues with this QT measurement, and not only calculate it, but look at it morphologically, and last but not the least, take evasive actions to prevent a potential death. Thank you very much.
Thank you, Dr. Rituparna, for a very precise presentation with most simplified manner. Thank you.
Thank you.
Thank you, sir. Thank you, chairpersons. Now next will be the award giving ceremony for the quiz winners. I request Dr. Parale sir and Dr. Pradeep Singhal sir to give away the awards. Okay. Awards will be announced by Dr. Rudrakshi sir. The quiz winners, the award winners will be given away the trophies on stage, and they are requested to collect the cash prize outside later.
We are going to announce the awards for the papers, posters, and MD and DM quiz. Congratulations to all of the participants. Now I request Dr. Parale sir and Dr. Singhal sir to come on the stage. First I will announce the second prize for the poster. He is Dr. Shivam Goel from Dr. VM GMC Solapur. Is he there?
Somebody can collect.
Dr. Shivam Goel.
Somebody collect on his behalf then.
Dr. Singhal will award him. Winner for the poster is Dr. Gunjan Shah. He is student of UN Mehta Institute of Cardiology and Research Center at BGMC Ahmedabad. Is he there? Okay. Now the awards for the paper presentation. Second prize, Dr. Vaijayanti Gandhi. She is the intensivist from the Ashwini Hospital, Solapur. She is not there. And I think she is the student of Dr. Parale sir only. The first prize goes to Dr. Aniket Inamdar. He is the consultant physician from the Umarga. Now we will announce the quiz prizes, the MD quiz results. The second prize goes to Dr. Swapnil Sapre and Dr. Prachi Hudlikar. Which college? VMGMC Solapur. VMGMC Solapur. Vaishnav from Solapur. And the winners for the MD quiz are Dr. Disha Arora and Dr. Samruddhi Devarkar. Science College, Mumbai. Congratulations. Please give applause to them. Just one thing. Wait. Dr. Aniket Inamdar, I think he is there. He is winner for the paper presentation. He can collect his award from Dr. Parale. First prize for the paper presentation. He is a consultant physician from the Umarga. Congratulations. Now the winners of the DM quiz, second prize, Dr. Pooja Prasad and Dr. Sudipta Mondal from Sri Chitra Trivendram. Congratulations. And the winners are Dr. Shubham Sharma and Dr. Gunjan Shah from UN Mehta, BJMC, Ahmedabad. I think they are not there. So, the congratulations to all the winners. Now, you have been awarded with the trophies. Please collect your cash prizes from the counter.
So we now move on to the last two segments for the conference. I invite Dr. Vinod Vijan sir for his talk on abnormal ECGs in normal patients, and for chairing the stage I invite Dr. Pradeep Joshi sir, Dr. Kale sir from Barshi, and Dr. Karvekar sir. Dr. Pradeep Joshi sir, Dr. Kale sir from Barshi, Dr. Karvekar sir.
It was to be a good morning, so good afternoon, friends. Got delayed, and I'm Dr. Vinod Vijan. I first of all wish to thank from the depth of my heart the organizers. I carry with me lifetime memories of Pandharpur and Akkalkot, and this is a brief intro. What is abnormal ECG and a normal heart? In 51, Frank Wilson had mentioned way back that many people are losing their peace and happiness by an erroneous interpretation of their ECG than being injured or killed by an atomic bomb. So when you see something which is not normal, it may mean that the person is okay, but ECG is abnormal. But it may even be a sinister finding which may be missed, leading to an heart attack. So normal and all is to be defined. there are various variations are in the normal ECG which occur especially even without heart disease. Most often it is seen in young persons and athletes, and this I will focus. And most important is many times the normal person may be mistaken, he may be labeled as abnormal, erroneously leading to harmful diagnosis of heart disease, unwanted treatment, psychological trauma, job recruitment failure and denial of insurance for which we are to be held accountable. This is a very important slide. Please try to understand everything is in relation to time. The prevalence of abnormal ECG increases with age. This was the ERIC study which was published in AJC that we see disease-free people and normal ECGs. You follow them over for 10 years. More than half, 53.4 will develop an abnormal ECG. Those who continue to have normal ECG would have a 41% lower risk of cardiovascular death or mortality and morbidity over 13 years than those who became abnormal. And even minor ECG abnormalities, which you and I say, let us pass it off, it is nothing, is found to have a 13% increase in cardiovascular death over 14. So this is very important. And what is important is even the reading competency. 1/3 of the ECGs will have meaningful error. 10% of ECGs are led to inappropriate management decisions, and it is higher among non-cardiologists than among the cardiologists. And even in cardiologists, 40% of them would be abnormal. So even it was found that when it comes to even cardiologists, even in trying to diagnose something which you think everyone should not make a mistake, like STEMI, only 79% of them could diagnose. And this is all Western data. And 37% concurrence when it is hypertrophy. And worst is among the cardiology fellows who are the first responders who take immediate decision before the boss is known, that they could interpret only 58% of the tests and miss 36% of life-threatening abnormalities. And so this is important because many times there are non-cardiologists who come and take away allied posts. So for example, this is the ECG which was, the senior was woken up. Sir, there is an abnormal ECG. And there is only abnormality was a T-wave depression in lead 3. And the boss said, please take it in deep inspiration. It disappeared. There are technical errors because of patient movement artifacts, electrical disturbances, grounding failure. And this is what was again shown by Dr. Narasimhan, the slide day before yesterday. And I've shown that the first thing shows it would be something you may sound code blue. But actually, if you see, the hemodynamics are all stable. Same thing, I'll show you examples of Parkinson's. But at the same time, you make sure that even the patient may be showing motion, excessive baseline wander, which may simulate something like a myocardial ischemia. Lead reversal is a very commonly seen, in spite of teaching our staff, that's what happens, reversal. And one common sense should be that, when you see the P-wave concordance is always there in lead 1 and V6. But if you find there is a discordance, think that there is something like reversal. And same way, when you place the electrodes, in spite of training, they put it little higher up, especially in a female, they feel it is embarrassing to bring it down. You will find this ST elevation V1, V2. I will show you the ECGs. Then there would be a poor progression of R because of least mismanagement may simulate intraventricular conduction defect or even a myocardial infarction. And again, when you are comparing ECGs for stress tests, you say limb leads, but you're putting them over the chest, vis-a-vis a routine diagnostic ECG, when you are putting the limb leads over the limbs. So they are not going to be same. And then comes computer interpretation, because that also is useful for recording, storing data, and comparing serial ones. But again, even if you go to computer identifying, there is an error rate as high as 30%, and even 40% of arrhythmias have been, diagnosed. Then comes the vendor differences. Differences if you are using analog and digital. Analogs are no longer used, I believe, is all digital. And then comes the over-reliance on this computerized interpretation. They are usually good if it is to report something normal. Again, normal, I'll tell you, between inverted commas. But when it comes to a diagnosis, it is only an adjunct. It is not to replace your decision. And then the future, we have been talking a lot about artificial intelligence, but please try to see that, that is again an adjunct. These are yet to be proven. Very commonly you see sinus bradycardia, asymptomatic. BP is good, okay man, what are you bothered? And once you increase the heart rate with exercising, that's good enough. But same way, frequent first degree heart block, second degree heart block, type 1 Wenckebach is normal, seen in a normal person. It is because of increased vagal tone. And this is one example of how you see Mobitz type 2. And this is the one. A resident will come and say, sir, this is a long pause. The patient might die. And this time we are going to put a Medtronic pacemaker because he has promised that he is going to sponsor me for Dr. Parale's conference. So tell him, my dear friend, this is a normal variation during sleep and it is a severe sinus bradycardia. But only long pauses up to 3 to 5 seconds you see. But these transient AV blocks also can occur in normal sleep and especially in obstructive sleep dyspnea and sleep apnea. So for the young people who are always trigger happy, they say to a man with a hammer, everything is a nail. And these are quick fix cardiologists. And you have to tell them, assess even the awake period. Don't only take your decisions during the sleeping. And for skip beat, skip the drug. Reperfusion arrhythmias, we have talked a lot about PVCs, AIVR. And again, we have seen that if you have AIVR and you want to give lidocaine, because this is ventricular arrhythmia, ventricular tachycardia, you will actually result in a serious bradycardia, especially in the setting of acute myocardial infarction. Now, there are changing perceptions. Again, what you have been taught is that we always say that there is a septal depolarization. And whenever you see the wavefront moves from the left to the right, so you are going to get a R in V1 and a small Q. Absence of that was considered to be normal. Okay, if it was less than 1/3 of the height of the R. But now, recent studies have again proven that if you do a cardiac MRI, CMI, you may find a septal scarring. So what you are reporting as okay may not be. Same way is the RS R' pattern, which may be normal in an athlete without the heart disease and certain Afro-Americans, it can be artificially produced. It's called an ISECON pattern. I will show you, especially if a patient has pectus excavatum, you don't expect, the ECG to be normal. But always remember there are pathology conditions in which you will have to rule out real bundle branch block here and a Brugada pattern. This is the early repolarization RS-R'. Now again, T-wave inversion, we have discussed a lot. Juvenile pattern is normal in children, even young adults, and maybe adults up to 1 to 3%, more common in women. But T-wave inversion should be less than 2 millimeter. Anything more than 2 millimeter, think that it could be pathological. What is known as subtleties, that means they are very subtle, but they are normal. This is the one where we saw early J uptake, and if you see trace 2, this is what the fish hook type of appearance seen in benign early repolarization. Most important here is to see the STT by T ratio should be less than 0.25 or 25%. If it is more, think of pericarditis. And then is the ISECON pattern where the staff has put leads little above and you will say, oh my God, this is an infarction. Just check, take it one lead down and you will find it is okay. Again, these are ECGs of early repolarization. Same topic I had talked about 35 years back, and we said that we are yet to learn. Today again I am on the same podium, and we are yet to come to many conclusions, but we are little better informed. So ST segment elevation without chest pain should be there. The terminal slurring is there, and terminal QRS notching. So this is very important. Although ST segment elevation is there, but that is not a definite criteria. So ST when present has a rapid upslope, and it is prominent in the right and mid precordial, and it decreases with exercise. Patient is asymptomatic. So 30% of the general population, young adults and athletes have this. Is it benign? We were always saying yeah, but not so. There is a variant in which tachyarrhythmias and sudden cardiac death can occur. So don't label it that this is what we have learned that benign repolarization is nothing to be done. So which are the malignant subsets? Where the J wave amplitude is more than 0.2 millivolt and the ST segment is horizontal or worse when it is down. So in here you have to not only rely on the ECG, go for the clinical history, family history of sudden cardiac death and genetic markers. That is why the differential diagnosis always remains MI, pericarditis, cardiomyopathies and the Brugada pattern, and understand that this is again common in athletes, but it leads to many false positive interpretations, and that is what is important. And these are again, this is a particular combination of a juvenile T wave pattern and early repolarization. Look at lead V4. There's a J point elevation. There is the splintering of the J point, and these are the combination which are seen. Was a normal patient. Again, the same thing here. But when you are seeing here, the elevation is there, and the ST by T ratio is more than 25, and the T wave ST segment is concave. This is the case of pericarditis. And the patient had no chest pain, but only positional pain, and this is what was found on So these are the ratio again, I have just, and this is the differential diagnosis of associated with pericarditis, myocardial infarction and early repolarization. You know about all this, that in myocardial infarction, it is only localized to the area, whereas in acute pericarditis, it will be both limb and precordial, and in early repolarization, only to the precordial. This is again a code blue warning. You'll say, oh my God, please, but the patient is sitting and reading a newspaper, so it can't be ventricular fibrillation. You can even see the QRS waves, but in between these are all motion artifacts. This is the Parkinson's syndrome and not atrial flutter fibrillation. This is a case referred by psychiatrists. Abnormal ECG, but it is only limb reversal. You can see. Again, palpitations where even one case I had missed. I just thought casually, oh, normal. And the interpretation told me, look at the PR shortening. So it is there to, and this is anorexia vomiting. What strikes you? Of course, abnormal ECG, but QT prolongation. This is one condition where is an acquired QT prolongation, which will correct. You treat that vomiting, metabolic alkalosis, hypokalemia. Dextrocardia will naturally appear different. If you are again having, very important, athlete, those who are having only first degree and second degree heart block, type A, but if it is Mobitz type 2 or third degree and VPCs and arrhythmias, that's a dangerous one which subside can produce with cardiac arrest, especially when they have got extremes of left and right axis. So to conclude, friends, treat the patient and not the rhythm. 12-lead ECG analysis, access the milieu interior. Sinus tachycardia itself requires no treatment. Do not treat asymptomatic arrhythmias. Identify the high-risk individual and understand that all antiarrhythmic drugs are pro-arrhythmic. This was what was given to me if you exceed the time. And friends, as the organizing chairperson of ECHO India 2000, this is my last slide, 23, I invite you all to this very prestigious conference in Mumbai, and which is the second largest attended after the CSI, but which has a hall occupancy always of more than 90%. So I hope to see all of you along with your colleagues. Thank you very much. Any questions, I would be most willing to answer.
Questions for Dr. Vijan sir. Till then, we request the chairpersons to felicitate Dr. Vinod Vijan sir. Thank you, sir. Meanwhile, I also request Dr. Gundeli sir, Dr. Nishikant Maske sir, and Dr. Mukund Rai sir to join the chairs. Chairpersons, please be seated, sir. Dr. Nishikant Maske, Dr. Gundeli sir, Dr. Mukund Rai sir. And prize winners who just were not there a while ago, the DM quiz winners, first prize winners, Dr. Shubham Sharma, Dr. Gunjan Shah from UN Mehta Institute of Cardiology, Ahmedabad. They are here. They would be receiving the first prize award from Parle sir. Dr. Gunjan Shah will be receiving the first prize for poster presentation as well. So they are receiving a team prize for winning the quiz, and Dr. Gunjan Shah is receiving his individual award for the poster presentation. Okay. Now I request Dr. Dargad sir to take over his talk. His topic is ECG in common systemic diseases.
Good afternoon to everybody. It's always been pleasure, to talk in our hometown and belong to Solapur and be proud of it. In fact, I was great desire to have this midterm ISECON conference in Solapur. I was with Dr. Parale and Dr. Gupta almost 3 years back. When it almost was decided, then the Tuticorin was taken, and next 2 years we lost in the COVID, and now we could have a physical conference. We happened this after 2 years of interval, and this was really a great arrangements and all that have been made by the Dr. Gurdat Parale and his team. I congratulate them, and I think we had an extra the academic feast and all that. My talk is very simple. Actually, we have been all discussing about the ECG in cardiology and respiratory and other diseases. So I'll be just covering few ECG changes. ECG can be helpful as in some of these systemic diseases which commonly know. So normally we took after these endocrine diseases, hyperthyroidism, all the electrolyte imbalances, these are amyloidosis, sarcoidosis, or there's some of the serious diseases we do get all the ECG changes are they're sometimes confused with the cardiac element actually. So in fact, we can just cover these few things actually. So I think the electrical axis, actually the heart, actually we actually all be discussing this. Beauty of this is that can provide valuable information on non-cardiac condition, which we are going to discuss today. And you can think of the various in pulmonary, I think Dr. Ketan has already discussed COVID, pulmonary embolism, long metastasis, like actually pneumothorax actually, gastrointestinal hiatus hernia, small bowel obstruction, acute pancreatitis or gastric perforation, and esophageal or rupture can give some ECG changes. In endocrinitis, of course, pheochromocytoma, and thyrotoxin hypothyroid also can give electrolyte imbalance, of course, hypo and hyperkalemia, and hypercalcemia also, and CNS, it's important, is subarachnoid hemorrhage can give some changes. The chronic obstructive lung disease has already been covered by the Ketan, so I will skip this thing. Pneumothorax can have very interesting thing, tachycardia, microvoltage, alterance, actually QRS complex. You can see the whole lung is pushed on the one side, so we'll get the changes, the R wave progression, all that thing will change. And of course, definitely there are also desaturation, so there will be tachycardia. This is the one thing we can see. Of course, acute pulmonary embolism already been covered, so I'm just keeping this, the T wave changes and all that been in detail discussed by the Ketan's previous speaker actually. Skeletal abnormalities, even simple kyphoscoliosis, this common ECG sign is a non-progression R wave because the whole lung is and chest it leads to the shifting of the heart, and this situation taking ECG one space below or above may increase the R wave voltage in the lead V3, because if you take a standard process, then you might not get the R wave that much in a patient with a kyphoscoliosis and all that. This CNS again, very important, is actually ECG can be abnormal in lot of CNSs. Subarachnoid hemorrhage is very common, and some cases stroke usually produces deep and broad T wave inversion. Coronary also produces deep T inversion in chest leads, but subarachnoid hemorrhage, the T inversion is very deep, broad, with some amount of QT prolongation also can be seen. Rarely in subarachnoid hemorrhage, ECG may show ST elevation, which mimics like an almost ST segment MI. Actually, there's one more example of this. Actually, we have this is a 30-year-old patient, subarachnoid hemorrhage. She was quite significant changes of repolarization with very long QT interval, mainly the expense of very wide T wave, and positive both leads, precordial inferior leads, and negative in both one AV leads. Sometimes mimic like an acute STEMI, but this was a case of subarachnoid hemorrhage, which was actually, of course, the patient's clinical history, and the CT imaging and all that proved that it was, these changes are very commonly, of course, you see in ICU setup. Other cerebrovascular accidents which you see, ECG, this is from a 65-year-old patient with CVA, and in acute phase shows subpericardial injury morphology type observed in the acute phase of the coronary syndrome, and ST segment elevation in some cases. It can be perimyocarditis, enzymes will be negative, and patient never complains of the chest pain, and ECG return to normal on following day, coinciding with the improvement of the clinical picture. So this picture is almost ST segment elevation and looking like a MI actually, or acute STEMI, and this patient had a stroke actually, in fact, and it improved actually. Neuromuscular disorders are actually or other condition where you can get, of course, a lot of myopathy. Duchenne's do have a cardiac involvement. They can have various types of blocks and actually these changes. This ECG in neuromuscular disease is often pathological and presents with the P waves, QRS complex ST changes, as well as serial different arrhythmias. Of course, Duchenne's is the most common myopathy which we see in the CNS. It's a progressive muscular dystrophy. ECG is almost always abnormal. The occurrence of this pattern suggests ventricular enlargement, particularly right ventricular enlargement will be there, and usually partial ABB RBB will be present. This classic Duchenne's muscular atrophy include resting sinus tachycardia, because these people are somewhat desaturated because of the cardiomyopathy, deep inferolateral Q wave changes, tall R wave in V1 due to underlying cardiomyopathy, which is often associated with the posterobasal fibrosis of the leg phase. Because these people also not only skeletal muscle involvement, there's the myocardial infarctions, and of course other various myopathies also there will be some ECG changes will be seen. This is again one more example of Duchenne's, classified into Duchenne's muscular atrophy. Resting tachycardia, deep inferolateral Q wave, and tall R wave in V1 and underlying cardiomyopathy often associated with this posterobasal fibrosis which you mentioned, and left atrial enlargement, and a prominent negative wave in lead V1, marked right axis deviation is also seen in this patient with, actually this might mimic like an inferior wall MI to you, but it was actually a case of Duchenne's muscular atrophy. The other, now we go to the GI disorders. Among this, the acute pancreatitis, you can see that symmetrical T wave inversions which are actually seen in all the chest layers, sometimes produce ECG changes, mimic acute coronary syndrome. This ECG change will include T wave inversion, ST segment depression, ST segment elevation, or absence of underlying cardiac pathology. Of course, diagnosis difficulty in symptoms, signs, symptoms of the abdominal are mimicked like a cardiac actually, can mimic those with acute coronary syndrome, and including epigastric and chest discomfort like nausea, vomiting, and syncope. But if you do an abdominal sonography or CT and with the enzymes high, and there is no other the chest discomfort or other hemodynamic symptom, this pancreatitis can be definitely. But these changes will be very similar to looking like an acute coronary syndrome. Then gastric perforation, esophageal rupture, where also we can get some of the changes actually. A hole in the wall allowing the contact between this peritoneal cavity and the gastric lumen. The gastric contents freely enter the general intraperitoneal space, and such that attempt chest pain again, dyspnea, epigastric pain, cardiac markers that are only not elevated. But actually you can almost have a clinical picture similar to acute coronary, and along with that ECG can be confused. But of course a careful history, and then if GI, of course the investigation there. Esophageal rupture also can cause, this is actually very close to the chest actually, where you will have a lot of vague symptoms actually of traditional Meckler's triad of vomiting, discomfort in chest, subcutaneous emphysema will happen when this actually rupture will happen, the air will be trapped. ST segment elevation mimic like STEMI can be seen in these two ECGs, whereas actually it's a esophageal rupture which has caused the pneumothorax to some extent and other things actually. Some of the endocrine disorders, then we go. The pheochromocytoma is one thing where you can have a lot of tachycardia, ST changes, arrhythmias, ST elevation associated with pheochromocytoma can be seen. Pheochromocytoma, of course, with a little difficult diagnosis, of course, unless we take a careful history, and of course the imaging, other things are done, and the cortisol levels and other thing done. But ECG changes can come in pheochromocytoma. This can be also a bizarre type of picture, staying in a pheochromocytoma with a lot of tachycardia, of course, actually. Other thing is hyperthyroidism is the most common thing which we see, is in thyrotoxicosis. Sinus tachycardia can be atrial fibrillation with rapid ventricular response. High left ventricular voltage, actually you can see this ECG, that your voltage, tachycardia, and sometimes atrial fibrillation, one of the causes which is reversible. Thyroid, most of the cases of thyroid linked with a grave disease or toxic nodular goiter. Elevated ST segment in leads, 2-3 AVF, as well as pressure-like symptoms, actually discomfort, increased troponin level also, and typical angina owing to coronary vasospasm is also can seen in 20% patients. So thyrotoxicity, apart from that, is now hypothyroidism, the other thing where you are going to get a lot of other changes actually. QRS widespread, inverted T waves, ST inverse deviation. Of course, it's a common thing. I think we can many times can diagnose patient, suspect bradycardia, low voltage, and T wave changes, and then history comes. Potassium, again, you have hyperkalemia. We commonly in ICU you see tall T waves, including producing P waves, QRS, EC change appears like potassium levels beyond 6 millimeter. In fact, to get a EC changes, you should be more than 6 microvelcard, and is mistaken for acute subendocardial ischemia. If hyperkalemia produces tall T waves, a narrow base, sharp acute ischemia produces tall T waves with wide base and blunt apex. Actually, this is some difference. Actually, again, the potassium will hypokalemia can have a U waves and low voltage T waves. The hyper produces low voltage waves of potassium U waves, and EC changes occur when potassium is less than 2.7. In hyperkalemia, it's lower than 6, and potassium to low to produce the EC changes. Of course, when the potassium is less than 1.7, significant ST depression, low voltage T wave abnormalities, U wave mimic like acute coronary syndrome. The apparent QT prolongation in the hyperkalemia differentiates it from the acute myocarditis. There will be definitely QT prolongation in this patient of hypokalemia. Again, calcium can produce hypocalcemia, hypercalcemia, both have shown. Hypercalcemia shows short QT interval, but hypocalcemia will show prolonged QT intervals. Of course, this is also a common clinical address. Whenever I think we're looking for QT interval, one should look for a calcium and all these things. In T waves, in anemia can produce some non-specific changes. The strong negative correlation between the HB level and the tachycardia ECG changes indicated that the HB level decreases. There is an increase in occurrence of tachycardia. Of course, these are all non-specific changes seen with a correction of hemoglobin will differ. Cardiac sarcoidosis, amyloidosis again will have a fraction of the QRS complex, left bundle branch wall or RBB pattern. ECG in a pattern with this cardiac sarcoidosis demonstrating incomplete right bundle block, left antifascicular block, and a left anterior midterm. This is a sarcoidosis. Almost similar changes will come in a cardiac amyloidosis also, either RBB, SBB, and RBB, and all amyloid showing QRS voltage. Of course, limbs leads and pseudo-infarction pattern in the chest lead. There can be a voltage decrease, of course. Now, because of the cardiac MRI availability, we were able to diagnose much more cases of amyloidosis sarcoidosis, which were previously not able to diagnose actually. So, psychiatric diseases then can produce some changes, and a lot of psychiatric drugs which are used for them also have some of the ECG. And almost every psychiatric drug has to be evaluated for QT interval prolongation before get an approval. So, these are some of the conditions we discussed. An interesting thing that we're discussing hyperkalemia. In patient of atrial fibrillation, the hyperkalemia brings him to a sinus rhythm. This is one case actually, a 73-year-old female patient was known case of AF and hypertension. NIH2 presented with complaints of drowsiness, decreased appetite, generalized weakness. She was on metoprolol, acetrom, lacildecton, digoxin, and telsartan, and we saw her potassium had gone very high. This is actually, the potassium was 9.8, which comes, the elderly lady, these were cases we presented with Yash and all this, and creatine also was 6.7. This actually echo showed LVH, EF was 55% with a diastolic dysfunction, and the type of ECG pattern we see, of course, very old ECG, typical. But here the patient is in sinus rhythm. The moment you correct his potassium, she goes back into the atrial fibrillation. Actually, this correction actually brought the patient. The hyperkalemia is a common side effect of heart failure therapy. The most common, of course, this patient was on lacildecton, telmisartan, which both we have to take it out and correct his potassium very rapidly. But once he's corrected, he became again into at AF. The common feature factor for the imperial this renal function drugs like ACE inhibitor, ARB, aldosterone antagonist, and the common ECG finding is tented TVs, prolonged PR interval widening. The mechanism is not clear in that how the hyperkalemia may associate with sinus conversion to atrial fibrillation. This because it's not clear, but the ECG reverted to sinus bradycardia after full shift of the potassium into intracellular to extracellular compartment. Hyperkalemia decreases the excitability of the atrial tissue and suppressing this ectopic beats and recurrent circuit. So sinus node is less sensitive to hyperkalemia than the atrial when the hyperkalemia get corrected, you go back to your original atrial fibrillation pattern actually. So this is an interesting observation. I think when patient of hyperkalemia is becoming sinus, it's a bad thing actually atrial fibrillation. That means your leg should check for potassium without any reason. If his actually potassium is normal, he will go back to his atrial fibrillation rhythm. So that is my last slide. And thanks to the organizers once again for giving me this opportunity and this interesting observation thing.
Thank you, sir. I request the chairpersons to felicitate Dr. Dargad, sir. The next talk, the second last talk for today, is by Dr. Durairaj Selvaraj sir. He will be speaking on target P wave, normal and abnormal.
It is almost good afternoon to all. I am honored to be here. Our great stalwarts spoke day before and yesterday. And I am not an electrocardiologist, I am an internist. I am extremely thankful to the organizing the IAC, especially Dr. Gurunath Parle, who was in contact with me for last 1 year. And my topic is targeting PV, normal and abnormal, which will help you to recognize most of the arrhythmias in your clinical practice. The sinus node is located in the proximal part of the right atrium, and depolarization occurs from right to left down and proximal to distal portion. The normal PV is positive, that's upright in lead 1, 2, AVF, V5, V6. Atrial repolation occurs during the time of QRS complex, so it is not normally seen. There is a slight notching of the P wave here, reflecting right atrial followed by left atrial repolation. A broad P wave, which is called a left atrial hypertrophy or abnormality, and is called P mitral. A narrow peak P wave is seen with right atrial hypertrophy or abnormality, is called P pulmonale. The P wave is negative always in lead AVR. The P wave duration is 0.12 second or less, and amplitude usually that is 0.25 milliwatt, that is 2.5 small square. P wave that are inverted or biphasic, negative positive in lead 1 to AVF and V4 are abnormal, always repeating an ectopic atrial focus. A negative P wave that follow a QRS complex are recorded due to retrograde ventriculoatrial conduction. Every P wave should be followed associated with the QRS complex, and every QRS complex should precede by a P wave. A PR interval should be stable. Normal PR interval is 0.5 to 4 seconds, measured from the beginning of the P wave to the beginning of the QRS complex. And inconsistent variability of the PR wave is called AV dissociation. Gradual progression of PR interval seen with ventricular or second-degree AV block. ECG clues to differentiate the mechanism of supraventricular tachycardia. Most important first step is Church-Lee P, that is look for the P wave. This is the RP-PR relationship, what Dr. Samuel Asiradam dealt with. There is no RP tachycardia, there is no P wave seen after the QRS complex, or it is the end of the QRS complex by RP interval is less than 0.08 second, what you see here. Short RP tachycardia is distinct P wave seen after the QRS complex, that is close to the QRS before it and a long distance from after it. And the PR interval, RP interval is again constant. The long RP interval, there is a distinct P wave seen that is closer to the complex that follows it, then it precedes it. This is a 55-year-old man person with a insurance policy for medical examination. BP is 160/90 and ECG is recorded. Here, it's a normal sinusism. Patient shows left atrial hypertrophy. You can see the P wave, which is broad in lead 2, 3, and again you can see a inverted P in V1, which is characteristic of left atrial hypertrophy. And QRS complex are normal in this case, and S wave depth in lead V3 is almost 25. The sum of the voltage meet and the criteria for LVH. Associated with are the ST segment changes, which are secondary to the LVH. It's again 66-year-old man to primary care physician for examination. He has grade 4/6 systolic decarcinoma murmur in the right sternal border and a cholesystolic murmur conducted to the apex, and ECG was recorded. This again ECG shows sinus bradycardia, left atrial hypertrophy and left ventricular hypertrophy. This is called early repolarization. This indicates a sinus rhythm P wave which is broad and have a increased amplitude there is significant notching of PV, especially prominent lead to A3. The second component of PV is greater amplitude than the first. Again, 54-year-old man present for evaluation of multiple episodes of syncope and palpitation, and X-ray shows a normal silhouette with a prominent hilar adenopathy. This is the ECG recorded. The patient shows a sinus tachycardia, a right atrial hypertrophy, left atrial hypertrophy, that is biatrial hypertrophy. The P waves are narrow, tall, and a characteristic of right atrial hypertrophy. And in addition, the P wave is very negative in V1, which is characteristic of left atrial hypertrophy, hence biatrial hypertrophy. And this is a 62-year-old man undergoes for surgery, aortic valve surgery, had a ECG taken. He shows normal sinusitism, right atrial, and see there is a broad P wave seen in lead 2, again lead 3, and inverted P wave seen in lead 1. So he has got biatrial hypertrophy, both right and left atrial hypertrophy. Along with this patient has got tall R wave in V1, V2, along with a tall R wave, tall P wave, it is a right ventricular hypertrophy. In addition, he has got a criteria of the LVH, that is more than 50 millimeters in height. I have given second one, they have changed my slide. This is again a 56-year-old man with paroxysmal lateral fibrillation and takes hydrochlorothiazide. 2 weeks after his injury in the knee, he was went to a doctor and the ECG is obtained, which shows a narrow complex tachycardia. This is atrial tachycardia. Patient shows inverted T wave in lead 2, 3, again in AVF, which is a characteristic of aortic tachycardia. Of course, this P wave is away from the inverted P wave is away from the RO. It is a long RP tachycardia. There are number of causes for a long RP tachycardia: sinus tachycardia, atrial tachycardia, atrial flutter with a 2:1 block, ectopy junctional tachycardia, atypical AV inertia with this fast flow, and uncommon re-entrant tachycardia is AVRT associated with a pre-excitation syndrome are common causes. The negative PV excludes sinus tachycardia. The most common etiology for would be an atrial tachycardia 1:1 AV conduction. This could be confirmed by blocking the AV node via the vagus nerve or adenosine. So the occurrence of a block with stable PP interval would confirm the atrial tachycardia. If the arrhythmia is abruptly terminates, the re-entrant arrhythmia, that is AVRT or AVNRT could be etiology. The treatment of atrial tachycardia when there is a rapid ventricular rate associated with the symptom is AV nodal blocking drugs. The long-term therapy for atrial tachycardia generally requires use of antiarrhythmic drugs, that is class 1, A, C, 3, and in some cases ablation of atrial focus may be used. This is a 40-year-old woman without a known medical history admitted to the hospital with abdominal pain, and the ECGA is recorded. You saw the rate of 180 per minute, and again when she was waiting in the consultation room, it is spontaneously there is a recovery, and another ECG, that is ECG B, is recorded. So white complex tachycardia with right bundle branch and shows a long RP tachycardia. This is a 60-year-old man present to the emergency department because of palpitation began several hours before presentation. has no known heart disease. Although, because of COPD, although was using the inhaler, has reduced the use of inhaler. This is the ECG-A which is taken. And this shows the two different types of QRS complex with two different widths. See, there is a RBP pattern with the white cone, and again there are only three supraventricular arrhythmias which are irregularly irregular. That is sinus arrhythmia. There is only one P wave with a stable PR interval, multifocal atrial rhythm called wandering anterior pacemaker, or the multiple atrial tachycardia when rate is more than 100, where there are more than P waves, and there is no constant PR interval. And the atrial fibrillation, no organized wave, P waves. So there are no clear or organized P waves in this ECG is due to atrial fibrillation. The QRS complex manifests two different widths already told. The narrow complex has a duration of 0.98 and the wide complex has a 0.1 with the typical RBP pattern. So the wide complex are then aberrant. This is not a typical of a aberrance associated with a tachycardia. And there is a long short-term error interval noted before this QRS complex. This is due to the what is called Ashman phenomena. The Ashman phenomena is most often associated with the right bundle branch block aberration. Kindly reflect because the bundle refractory period is slightly longer than the left bundle. The Ashman phenomena may last for more than one complex. This is a 22-year-old college student who has the sudden onset of a palpitation and lightheadedness while walking on his last class, and the ECG was taken, and when ECG was recorded, when he was waiting, then it has become normal and another ECG-B was recorded. See, this is a narrow complex supraventricular tachycardia. Say no RP tachycardia. You cannot see the P wave before or after QRS complex. And if you see closely, there is a ST segment depression seen in the V2 and V3. Again, a 19-year-old woman has a history of intermittent palpitation present as emergency department after developing sensation of a palpitation. The ECG-A was recorded. Again, during waiting, it became normal and ECG-B was recorded. This is a narrow complex tachycardia, short RP tachycardia. If you closely, if there is no P wave, closely see, there is a small upright wave seen in V1, again in V2, and you can see a inverted wave in the lead 2, lead 3. These are actually the P waves. The QRS complex duration is normal, 0.01 second, and there is a leftward axis. There are no P waves seen before or after the QRS complex. The P wave can also be seen in lead V4, V6 as a notch of the ST segment, also in lead AVF. The RP interval is 0.1 second and the PR interval is 0.3 second. It is a short RP tachycardia. This is my last slide. And an 18-year-old man is seen 3 times in the emergency department because of palpitation. On his first 2 visits, ECG-A and ECG-B are recorded, but a diagnosis cannot be definitely made based on this ECG alone. It is the ECG-C which shows a narrow complex tachycardia. This is a ECG-B, and which again shows a narrow complex tachycardia. There is a sudden conversion to the normal rhythm, and an appropriate therapy was given, and ECG-C was recorded, and after that, again, when the rhythm became normal, ECG-D was recorded. This is ECG-C, and this is ECG-D. Yeah, the ECG-A analysis, patient has got a narrow complex supraventricular short RP tachycardia. It is a orthodynamic atrioventricular tachycardia. You can see there are notches seen in the lead 1. A shows a regular rhythm at a rate of 220, duration is normal QRS, and there are no obvious P wave, but there are notches seen on the ST segment and the notches in the upstroke of T wave and also in lead 1. There are also notches lead AVL, which is same as relationship to QRS complex. There are regular and have a constant RP interval, while the PR interval is 0.2 seconds. Hence, this is a short RP tachycardia. Again, the causes of short tachycardia: sinus tachycardia, atrial tachycardia, atrial flutter with the two-stone block, AVRT, and unusual form of AVNRT. A typical AVNRT, which is due to dual nodal AVD pathway, stems slow fast. The slow pathway conducts antegrade to the ventricle and the retrograde conducts to the atria. Hence, there is no POA seen as there is simultaneous atrial and ventricular activation. With slow AVNRT, the fast pathway conducts slow, so provided short RP tachycardia. Thus, ECG clinical history do not provide any additional clues regarding the etiology of this tachycardia. ECG-B is from the same patient as 55A, hence it is short RP tachycardia. Notches again seen in the above leads, that is V1, and again in AVL. The arrhythmia terminates abruptly after the 19th QRS complex. There is abrupt termination of QRS complex, the 19th complex, but has the same morphology of the QRS complex seen. Hence, the tachycardia terminates with a retrograde P wave that is non-conducted. A SVT terminates with a non-conducted retrograde P wave originates within the AV node, that is AVNRT or ectopic junctional tachycardia, or involves AV node as essential part of the circuit. In contrast, the atrial arrhythmia terminates in the absence of atrial activity. Therefore, the etiology of tachycardia involves AV node. The QRS complex second pass has the same duration and morphology QRS complex sinus tachycardia. There is no P wave seen before QRS, but there are a notch in the again ST segment best seen in lead 1, V2, as it looks like an SAF, lead 2 AVF. This is also a retrograde P wave. However, the RP interval is shorter, and that's seen during the tachycardia. This is a escape junctional rhythm with a retrograde P wave. Another pulse wave pass is seen thereafter the sinus P waves at a rate of 90. The QRS complex have an increased duration with the two different morphologies and various PR interval. The etiology QRS is not clear. However, several of these complexes have a short PR interval and slurred upstroke suggesting a delta wave. And this is ECG 50C, same patient from A and B. Arrhythmias irregular, and not obvious. There are only three irregular. There are only three irregular rhythm, that is sinus arrhythmia, again atrial fibrillation. There are long RR intervals that end with a wide Q wave and a short RR interval end with a narrow QRS. With our rate-related aberration, the wide complex are seen with a faster rate, while narrow QRS complex are seen with a slower rate. So, absence of any association between the QRS complex, which is typical of pre-excitation, and it's a WPU, not typical of rate-related aberration. Since the patient has a WPD etiology tachycardia AVRT, the QRS complex is narrow and normal morphology. Indeed, AVRT most often present with short RP tachycardia, and one of the most common cause for etiology is the AVRT. The ECG-D is the baseline ECG for this patient with ABC. It's a regular rhythm data 96. There is a P wave before each complex, stable PR interval. However, P wave is broad, while there are PR segments very short. The QRS.
Excuse me, sir.
I am finishing. See, most important point is this: you have to give AV nodal drugs for blocking the supraventricular tachycardia. Since there is here, you should not give the regular drugs like your beta blockers and others, and you must give drugs like procainamide and the epitylate, which will act on the accessory pathway and revert the rhythm to go through AV node, and these patients will be safe. Otherwise, if you give other drugs like amiodarone, there is be increased conduction through the atrial to the tract to the ventricle, and the ventricle may go for a rate of more than 350, and even in a normal head you will precipitate a ventricular fibrillation and a death. Thank you very much for your patient hearing. Any abnormal inverted P wave lead to 3 AVF is always a ectopic. Please concentrate on the P wave. You can make lot of diagnosis and careful in using the drugs. Thank you very much.
Thank you, sir. I request the chairperson to felicitate Dr. Selvaraj, sir. Next, I request Dr. Dharmendra Jain, sir, to start his talk. He will be speaking on which AV blocks other than first degree AV blocks don't need a pacemaker.
I would like to thank organizer, especially Parale sir and the scientific committee and organizing committee. This is, I am between your lunch and I will finish in less than 10 minutes, don't worry. So it's very interesting that which AV block other than first degree AV block do not need pacemaker. So we all know the indications. So first I will describe the indications in various conditions, and then you got to know that where we should do not do the pacemaker. So we all know the conduction system, SA node, AV node, and bundle branches, and the blood supply where we have SA node artery which is having dual supply, and the right bundle is also having dual supply, and like that. And then this first degree AV block, we all know that more than 0.2 PR interval with the QRS may be normal or abnormal if bundle branch is there, and rate will be the underlying rate and regular sinus rhythm. So this is first degree AV block. And other than this, where we can go, do not need pacemakers. So 2 slides for indications of pacing in AV block. So the pacing is indicated in patient with sinus rhythm with permanent or paroxysmal third degree or second degree type 2 infranodal 2:1 high degree AV blocks, irrespective of symptom. It's a class 1 indication. Pacing is indicated in patient with atrial arrhythmia, mainly AF and permanent and paroxysmal third or high degree AV blocks, irrespective of symptoms. And patient with permanent AF in need of pacemaker, we should prefer ventricular pacing with rate response, VVIR. Then pacing should be considered in patient with second degree type 1 AV block that causes symptoms or is found to be located intrahazian or infrahazian TP study. This is 2A indication. And in patient with AV block, triple D should be preferred to avoid the pacemaker syndrome. And permanent pacemaker should be considered in patient with persistent symptoms similar to the pacemaker syndrome and clinically attributable to first degree AV block. PR interval is very high, PR more than 0.3. So it's a 2A indication where patient is having symptoms because of only prolongation of PR interval. So he will have symptoms like pacemaker syndrome. So pacing is not recommended in patient with AV block due to transient causes that can be corrected and prevented. That is the most important thing, that the transient causes which is causing the AV blocks other than the first degree AV block. So these are preventable causes or correctable causes, and this is the, I think, class 3 indication. We should not do pacemaker. These are the some of the causes where AV block is expected to resolve and unlikely to recur, like drug toxicity or Lyme's disease, some infectious causes like Lyme's, trypanosoma cruzi, rheumatic fever, myocarditis, Chagas disease, Aspergillus myocarditis, varicella zoster, valve ring abscess, toxins like mad honey, cardiac glycosides, ischemic and infarctive causes like AV node block associated with infraval MI, is usually reversible. His Purkinje block associated with anterival MI. These are some drugs which affects the AV node, 1A, 1C, 2, 4, 3, 4, and digoxin. So the drug should be removed if the symptomatic AB blocks occurs rather than doing a permanent pacing. AB blocks may be associated with aortic valve surgery, septal alcohol ablation for HCM, percutaneous coronary interventions to the LAD or ablation of the slow or fast pathway of the AB node. AB block after cardiac surgery is also seen in 1 to 5% of cases. So these are usually transient postoperative AB blocks with return of normal AB conduction within 7 days, and we should avoid permanent pacing in these cases. Some degenerative disease like Lenegre, Leves, non-compaction cardiomyopathy, nail patella, mitochondrial myopathy, rheumatic diseases, infiltrative diseases, neuromuscular disorders, these may be having a persistent first degree AV block in the presence of bundle branch block that is old or age indeterminate. So these conditions may cause some AV diseases, AV node. So there are certain indications where we should do pacing, otherwise we should avoid it. Recommendation of pacing in bundle branch blocks. So pacing is not recommended in asymptomatic bundle branch block or bifascicular blocks. Similarly, cardiac pacing is not indicated in absence of documented cardioinhibitory reflex in a case of reflex syncope. So pacing should be avoided. And in patient with unexplained falls also, pacing is not recommended in patient with unexplained fall in the absence of any other documented condition other than the unexplained syncope. And it is not recommended in patient with unexplained syncope without evidence of sinus node dysfunction or conduction disturbance. After acute MI, implantation of permanent pacemaker is indicated with same recommendation as general population, and when AV blocks does not resolve with a waiting period of at least 5 days. So after acute MI, we should at least wait for 5 days before considering the permanent pacemaker. In selected patient of AV block with interval MI with acute heart failure, early device implantation with CRTP or CRTD may be considered to be indication. Pacing is not recommended if AV block resolves after revascularization or spontaneously. We should always wait for at least 5 days after acute MI before considering the permanent pacemaker. So after cardiac surgery also there are definite indications for permanent pacemaker implantation, but patient requiring pacing after mechanical tricuspid valve replacement, implantation of transvalvular RV lead should be avoided. We can put the epicardial lead or we can go for the CS lead. After TAVI also, if there is no need of prophylactic permanent pacemaker before TAVI in patient with right bundle branch block and no indication for permanent pacing. But after TAVI, there are certain indications for permanent pacing, like it is recommended with complete or high grade AV block which is persisting 24 to 48 hours after TAVI. Then after 48 hours we can think of permanent pacing if the complete heart block is there. It is recommended in new onset alternating bundle branch block also after TAVI. These all are class 1 indications. Early permanent pacing should be considered in patient with pre-existing RBUB who develop any further conduction disturbance during and after TAVI. 2A indication is there. Similarly, in congenital heart disease, in patient with congenital complete or high grade AV blocks, pacing is recommended if one of the following risk factor is present, that is class 1 recommendations like symptomatic complete AV block, pauses more than 3 seconds, or broad QRS escape rhythm, prolonged QT interval, complex ventricular ectopy, or mean daytime heart rate less than 50 beats per minute. Otherwise, we have to rethink before going for the permanent pacing. And this is my last slide. Permanent pacing implantation is not recommended in patient with fever, and permanent pacemaker implantation should be delayed until the patient had been afebrile for at least 24 hours. Thank you.
Thank you, Jain sir, for a quick presentation. I request the chairpersons to the ISECON conference. Thank you, the organizers, participants, moderators, teachers, all of us, all the event management team for making this a big success. Thank you. Thanks a lot. This will be followed by lunch.
Once more, sir. Thank you.
Hello?